Hello, good morning, everyone. Can everyone hear me?
Yes, sir. Good morning, sir.
Yes, Zishan. I don't have option to make Michael co-host.
Sir, can you make me host, if possible, sir? On the right side of the screen, top right side of the screen, you can click Sir Michael,
Yeah,
and after that, you can make him host. There's a pop-up list which will come in
yeah, yeah.
front of you, sir.
Yeah, there is a drop down and it says make host, and there is no
Yes, sir.
co-host. Okay, let me
Sir,
make it.
yes, sir.
Should I begin?
Yes, Amayal, go ahead, please.
Okay then. Let me just go back up again. Seems that I've lost, my video has been lost, but never mind.
Yes, Amayal, go ahead, please.
Okay, all right, should we begin then? So as the first slide shows, my name is Shaista Hussain, and I'm currently working as an assistant professor at the Shifa College of Pharmaceutical Sciences, which is an entity of Shifa Tamir Millat University. So I've been kindly invited to the first conference of Giving Back to Pharmacy in Pakistan, Innovation in Pharmacy Conference. And I was asked if I could sort of briefly outline and share the new Master of Philosophy Clinical Pharmacy Practice program that we are about to launch in 2021. So before I actually go through the outline, I do want to give a bit of background, a platform as to why we felt that there is a need for such a program in Pakistan. Now, generally, as a profession, I'm sure you're all aware that pharmacy has evolved tremendously over the last few decades. We've sort of gone from the very beginning, the roots of being sort of apothecaries, to pharmacists, consultants, and independent prescribers as such. Now, many countries, they're moving towards a more patient-orientated clinical role for pharmacists, and they are moving towards integrating pharmacists into a multidisciplinary team setting alongside doctors, nurses, social care staff, etc. And what has propelled this evolution is that we are now putting patients' quality of life at the core, at the forefront of patient health care. We want to improve patients' quality of life with safe and cost-effective medicines. This is a growing priority for healthcare policymakers worldwide, and the rest of the globe has to sort of start moving along with it. Pharmacists are fast becoming recognized as the medicines experts, and they're well placed with their education and training and development to promote quality use of medicines in a healthcare system. So if we look at the developed countries, their healthcare workforce at the moment is including an ever increasing number of non-doctor professionals. That would be nurses, that would be pharmacists, and they are undertaking clinical work in the medical domain. A perfect example is of a pilot study that took place many years back, where pharmacists were placed in the A&E accident and emergency setting, and they were actually triaging the patients as they were coming in. They were doing their medication history taking, which was once traditionally a junior doctor's role. So this is how our profession is evolving, and quite rapidly as well in the last 2 decades or so. So we, as an educational institute, need to be able to keep up with this evolution. This next slide, which I'm going to share with you, is really just a short video that reinforces the changes that have occurred to our pharmacy profession. It sort of starts to bring home what sort of standards are now expected of us as pharmacists. It's focused, the film is focused on a patient-pharmacist consultation, and I'd like you to pay special attention as to how the pharmacist effectively communicates with the patient and her carer. It really is a good demonstration of person-centered care and shared decision-making. This is the ethos that now heralds patient care. So fingers crossed, the power of technology will not let me down, and I can play the video.
Hi, Dorothy, lovely to see you again. It's Nina, I'm the pharmacist. Oh,
Where was last week?
good to see you. Gareth, thanks for coming in. So, we have this medication medication review scheduled.
Yeah.
And really this is your chance to have a chat with me about whatever you think is important. We're going to talk about your medicines, Dorothy. So what would you hope in terms of medications altogether now?
Worse fall last week.
Oh, okay.
So she had a bit of a bump with osteoporosis. Obviously, got some concern that I'm going to come home and she's going to be stuck there, having not been able to get up or something. So I was thinking she's on so many different medicines.
I mean, obviously, there are lots of things that can contribute to falls, but medicines, you're quite right, are one of them.
Yeah.
So I was looking through your list of medicines, because you're on a lot of them. And I was looking, and actually there were 3 medicines that did make me think, I wonder if together they could actually be making the risk of falls worse.
So I think more unstable.
Yeah, so I think we're kind of on the same page here.
Okay, great.
So it sounds like what might be useful will be to think about all the medicines and see if any of them could be causing you to fall. So the ones I was thinking of were, first of all, the mirtazapine.
Yeah.
So that's a medication for depression, and I can see from my records, Dorothy, you've been taking the mirtazapine for about 2 years. Is that right?
Yes, I think so.
Yeah, that's right.
Yeah.
Yeah. You don't really like taking all your pills in the evenings that often, do you? But you don't really enjoy it that much. Sometimes it's quite hard. So
It's all right. I have a list. I tick them off when I take them.
yes,
It keeps nagging me.
she's very good with a list, but it's actually
Actually taking them.
can be quite an ordeal.
So is it a swallowing problem?
Well, no, it's not so much that. It's just you just don't like to drink a lot of water before you go to bed, do you? So it's the
Right,
timing of
'cause-
things is.
Yeah.
Okay. So that's more about maybe getting up in the night to go to the toilet.
I think it's a lot to with the concerns about the incontinence and stuff as well.
Yeah, I understand
Contributing
that.
factors.
And the other one I wanted to ask about was the zopiclone, which I know was given about 6 months ago from my records because there was
Yeah.
some trouble sleeping.
Yes,
So what's the sleeping situation now?
we seem to be getting off all right, Annie. Wouldn't you say so?
I wake up very early in the morning.
Right. Okay, but going off to sleep's okay.
Yes.
My thoughts were that if falling is a problem,
Mm-hmm.
the mirtazapine together with the zopiclone could make the risk of falling worse.
Oh, really? It would be okay.
Yeah, the effects, the sleeping effects can be additive.
Okay.
So those two together might be something we want to reconsider. And my view would be that if the sleeping really isn't a problem now, I don't know how you'd feel about us trying to wean off the zopiclone.
Well, would it be a problem if we try taking that back, and then if you do find it really hard to go to sleep in the evenings, then we could talk about putting that back in, or maybe considering something else? Because
Yep. And I think that's really important that you've mentioned that, because the whole point of this medication review is not just to stop something and be done with it, but it's to work with you in an ongoing way so that we can try something, see if it works. If it doesn't, make a change and then try something else. Because the whole point is to get the best for the medicines. We want the medicines to help you, Dorothy. Now, there is another medicine that Dorothy's taking for the incontinence.
yes.
And that can sometimes make you a bit unsteady, but I think we have to do one thing at a time.
Mm-hmm.
And the obvious one is because Dorothy's taking 2 medicines for sleep, let's just see if we can cut that down to
do
1.
without that one. Let's do
Yeah.
that one.
So what we're going to do is take away one of the medicines because you probably don't need it anymore. And we'll see how you are. What I'd suggest then is we're going to cut the dose of the zopiclone down to half.
Okay.
And then if you're happy, we can speak on the telephone
Sure.
and you can just give me an update as to how we're getting on.
Brilliant. All
Okay?
right.
And I'll get in touch with your GP. And if for any reason Dorothy needs to go to the hospital or to the GP, you need to inform them what we're doing, and I'll make sure the GP record is updated.
Okay.
And then we'll look at it again. We'll speak on the phone next week. How does that sound?
Sounds good. Is
Brilliant.
that all right with you? Feel okay?
Yeah.
Okay? So I'm going to speak to Gareth next week and see how you are.
Right.
All right?
Yeah.
Save you coming in. But I'll look forward to seeing you next time you're out and about.
Oh, yeah.
Take care. Lovely to see you.
Thank you very much.
Thanks very much.
Okay.
So, does anybody have any thoughts after watching that video? Hopefully, it is, as I say, demonstrates how the traditional medicine-focused role of the pharmacist is being challenged. You know, we are fast moving away from just dispensing prescriptions. If anything, that is now being moved towards the more the technician, the pharmacy technician role, to release the pharmacist away from the dispensary, the pharmacy, and out onto the wards where most of the healthcare in hospitals will take place, and in community pharmacies, they're at the forefront giving consultations as shown in that video. So where the traditional medicine focused role is being challenged, it's argued that the clinical pharmacist of the future should be capable of confidently and competently managing patients at an advanced clinical level, and with health assessment and diagnostics and clinical examination skills comparable with that of an advanced clinical practitioner. So we are seeing now more and more a variety of qualifications, sort of postgraduate qualifications, that are becoming a necessity for pharmacists if they are to be employed and successfully carry out the roles now that are expected of them. So that's what it really boils down to. Pharmacists now need to be in possession with not only a basic knowledge of science, like we've always been taught, but also the fundamentals of clinical therapeutics and practice as well. And so this is basically what has led to our institute, Shifa College of Pharmaceutical Sciences, to revamp the pharmacy undergraduate curriculum, the PharmD curriculum, and also the method in which it is going to be delivered. So we're introducing an integrated undergraduate curriculum, and we've also now gone one step further. And like I mentioned, we will soon be implementing the first ever MPhil clinical pharmacy program in Pakistan, inshallah. Now, this MPhil clinical pharmacy program, it's been designed to respond to the societal need to improve the use of medicines. And that is ever an important priority here in Pakistan. I've been here now almost 5 years, and having worked at Shifa Hospital as well, I've seen that there is a dire need to improve and rationalize the use of medicines amongst our population. This course content, which is sort of outlined here in this slide, that's going to hopefully provide the specialized advanced education and training that is going to be required to equip pharmacists with the clinical competencies necessary to practice in team-based direct patient care environments. So it's a normal MPhil program in that it will expand over 2 years. And the first year will be complementing theory with practice, and the second year will constitute entirely of research, with obviously the completion of a thesis. And the whole sort of MPhil program is going to integrate and sort of elevate what has already been taught in the PharmD program. So that will be the integration of pharmacokinetics, pharmacology, pharmaceutics, etc. All of the entities that make up the pharmacy profession. So as always, we have aims in our programs, and the clinical pharmacy practice program is no different. So this slide is outlining our course aims. So we have a significant focus on acute and chronic conditions and how we should manage them. Obviously, we have to have up-to-date information on current guidelines and how to implement them in practice. We are also hoping to provide skills in medicines optimization, because that is the brunt of rational medication use. We want to improve communication skills amongst other healthcare providers. So we have modules which promote effective communication and consultation. As you saw in that video, that is quite key in being able to ensure that the patient understands fully what is expected of them when they are taking control of their medicine use. And also we want to be able to impart skills where students are able to critically evaluate healthcare literature. that is also quite something that I've experienced is needed here in Pakistan, to be able to take a trial or a paper and be able to sort of tear it apart, critically evaluate, and be able to make decisions about whether a particular drug that's come out on the market is actually as good as it says in the paper that it's published in. So they should also be equipped with those skills about critically evaluating healthcare literature. So this is really a breakdown of the program curriculum. So in the first year, we are focused on 5 modules, which includes the therapeutics module that is very much theory-based, the clinical pharmacy application, clinical rotations, clinical pharmacy learning, and research analysis. And in the second year, as I mentioned, we are focused entirely on the students performing a research project. Now, these individual modules, they're carefully designed to cater for the comprehensive knowledge and application that is necessary to enhance rational and responsible use of medicines. And they will all be delivered as tutorials, lectures, practical placements, and small group teachings, to name just a few. So the therapeutics module, we will be focused on 6 major symptoms of the body, and that will include renal, cardiovascular, respiratory as some of the main ones. And it will be centered on clinical presentation. So that would be about understanding symptoms and etiologies. It'd be centered on diagnosis, being able to interpret clinical lab data, patient's clinical presentation, and they'll also be taught the principles of disease management. So what are our aims of disease management? What are the modes, i.e. the interventions? What monitoring is going to be necessary? What assessments, counseling, etc.? The clinically relevant information on diseases and their consequences and the context in which the diseases will develop, and that also includes patient circumstances as to what may have caused the development of the disease. This will all be taught, and focus will be given on providing comprehensive treatment pathways as part of the pharmaceutical care of the patient. The clinical pharmacy application module, where here the students will experience teachings of many aspects of patient-related care. So this will include the principles of optimizing medication therapy and promoting health, well-being, and disease prevention. All of this will be covered. The students will engage in the concept of person-centered care and shared decision-making. So we're moving away from being the sort of parental role, where perhaps in the past doctors just used to instruct the patient as a parent would instruct a child to take medication like this, like this, like this. We're moving away from that traditional parental role, and we focus more on person-centered care and shared decision-making. So the patient is actually going to be empowered in their health and well-being, and how they're going to be managing that and taking control of that. As well as medicines optimization, there will also be the topics of patient safety and risk management, and this will be covered with subjects such as adverse drug reactions and interactions, as well as medicines governance. Students will develop the skills that are needed to acquire information from a variety of human and laboratory sources, and they're going to hopefully be able to analyze and interpret data, and finally be able to translate such findings into a rational diagnostic or therapeutic plan. That is the end outcome, that they are able to amalgamate all the data that is in front of them, be able to skillfully filter what is necessary and what is important, what is a priority, because obviously there are time constraints, and eventually they should be able to devise a therapeutic plan, a care plan, if that's what we like to call it, for the patient on an individual basis. We're also touching upon public health, because obviously you can have clinical pharmacists in the community as well, and they are very much involved in offering health and advice with regards to services such as smoking cessation, obesity, drug misuse, etc. The current state of affairs regarding infection and antimicrobial stewardship will also be explored by these students. So essentially this module will also equip students to design, conduct and analyze prescribing audits, because that is a fundamental part of a clinical pharmacist activity to enable them to assess whether their service is of a certain standard or not, and where there are deficiencies, and they can identify them and hopefully improve them. So being able to interpret, design, conduct prescribing audits and analysis is an essential skill for clinical pharmacists. And as I've mentioned, effective communication and consultation, well, that's an essential requirement for clinical pharmacists to perform their functions effectively, and that will also be studied within this module. Research is research. So within this module, we will be splitting the topics under methodology. So they will be taught all of the methods and study techniques and statistics, all the different types of studies, etc., their values and their advantages and disadvantages. So they've got a real sort of solid foundation about all the methodologies that are involved in research. So it's going to be sort of an extension of their undergraduate course per se. So we want, the objective of this component, this module, is to elevate the students' perception of how research is fundamental to the progression of our clinical practice. So they will be, although the research will be in their second year, we will also be using the first year to start helping them prepare for their final year project. So this research module is hoping to also further develop their critical appraisal skills. So again, they may be able to practice assessing and evaluating literature for new drug developments with expert opinion. So we will be offering them sort of a breakdown, a table that they can follow if they wish in the first year to sort of get their research project approved and finalized by the time they reach their second year. Modules 4 and 5, well, they consist of clinical rotations and clinical pharmacy learning, and they're designed to sort of complement each other. So obviously it's all well and good to have the knowledge, the theory behind clinical pharmacy practice, but it's actually having hands-on experience and putting that knowledge into practice, well, that's instrumental to good clinical pharmacy practice. So these modules are included to develop the competency of performance. And what is performance? That's being able to demonstrate how to use the knowledge and skills to perform their professional functions effectively. So this is what really the aim is of these clinical rotations, clinical pharmacy learning. So we are very privileged to have Shifa International Hospital as our sister institute. So our clinical rotations will be performed at Shifa International Hospital. These clinical rotations are going to be 2-hour-long sessions, and the students will be given the opportunity to interact directly with patients and other healthcare professionals. So we're hoping that they'll be able to observe and participate in specialist departments like the anticoagulant clinics and heart failure clinics, that they will be involved in discharge counseling services, outpatient consultations, to name a few. They should also be able to exercise their skills from their therapeutic and clinical pharmacy application modules to perform tasks such as medicine reconciliation and medicine history taking as well. Now, to support the students' performance, we are going to assign them learning activities, and these learning activities will facilitate students to apply their knowledge in the hospital setting and familiarize them with the daily clinical pharmacy practices. So that would be drug information, adverse reaction reporting, analysis, looking into patients' notes. We will be giving a lot of training in how to effectively go through patients' medical notes and pull out the information that is required of you. The clinical pharmacy learning sessions are also 2 hours in duration, and that will be back to back with the clinical rotations. So they will immediately follow the clinical rotations. And these sessions are really to facilitate the group interaction and discussions with real patient cases, what they may have picked up from their clinical rotations. We will also introduce simulation exercises with role playing. We will have many clinical evaluation exercises to encourage problem-based learning in this clinical pharmacy learning module. So these sessions will also serve to discuss articles relevant to practice to facilitate evidence-based learning. So throughout the program, students are going to be assessed with therapeutic assignments, and then they will have an annual exam. And so they have to obviously do well, pass a certain threshold with their therapeutic assignments to be able to then sit the exam at the end of the year. As I mentioned also, in the first year, they will be sort of supported with the formulation of their research project. So they will be provided with a structured timeline for their research year to help them plan and execute their projects in an organized manner. This last slide, well, this is an algorithm from the NICE clinical guidelines, and it really is, it really sort of puts in a nutshell what our clinical pharmacy practice is aiming for. In general, as I mentioned, we want to be competent in being able to clinically assess and manage patients who may have multimorbidities. And so, for example, our clinical therapeutics modules are hoping to serve steps 0, step 2, and step 4. Our clinical pharmacy application module will hopefully develop the skills to be able to perform steps 1, 3, and 5. And the practical and research modules will help to put it all into hands-on practice. So this final slide is sort of our model of where we want to get with our students by the end of this program. So I thank you for listening, and this is my contact email address should you wish to discuss any further queries, questions you may have. Any questions?
Thank you, Dr. Shaista. That was a very well integrated teaching plan and modules. These are the team of the need of the time, and may your efforts be ever so fruitful. Thank you so much for the session.
Thank you very
without
much.
further ado, I would like to introduce you. You're welcome. Without further ado, I would like to introduce you to our next speaker, Dr. Michael Frodiger. He is a board-certified clinical pharmacist and USP 795-797-800 compliance supervisor at St. Agnes Medical Center in Fresno, California, USA, and at Valley Children's Hospital in Madera, California, USA. He also consults with pharmacies engaging in sterile and non-sterile compounding, including hazardous drugs. He is an expert in areas such as regulatory compliance, risk assessment, clean room technology and design, sterile compounded drug stability and administration, and medication safety. He assists clients with the development and maintenance of policies and procedures complying with USP 795, 797, 800, and California-specific regulations. He is a board-certified pharmacotherapy specialist, board-certified sterile compounding pharmacist, and advanced practice pharmacist. He also holds an adjunct faculty position at California Health Sciences University in Fresno, California. His introduction in itself must have intrigued many of you to learn a thing or two from him. His topic for today's session is why you should establish sterile preparation services in your hospital. With this, I would like to hand over the session to Dr. Michael Frodiger.
Good morning, everyone. It's a privilege to be able to speak for you today. I'm just trying to make sure you can see my screen.
Yes, we can, Michael. Go ahead, please.
Oh, excellent. Okay, thank you. All right, so what I would like to talk about today is the importance of establishing a sterile preparation service in your hospital and exactly why that is so important. So I divided it into 3 learning objectives. We'll first look at the importance and what happens if there is not experts at your facility, and what can happen with drug errors, adverse events, that sort of thing. Then I will talk about how to go about designing the compounding service and what references you'd want to refer to design a service. And then finally, what are these references? This is, I would say, is one of the most difficult barriers because there's no go-to single reference for everything. You have to know what you need to know, and for most people, they do not know that. So I'm hoping to be able to help every aspiring compounding pharmacist out there, as well as medication safety pharmacists, to have a good start in this field. So with the first learning objective, to understand the importance, the number one thing we have to remember is that it's all for patient safety. That's going to be number one in all of this. And what goes into that is an organized sterile compounding service where we look at the quality of the product, the education of the staff, of course, as well as the safety of the staff. But everything that we're going to do, as I talk about, it's all to make uniform, consistent product that will be safe, as well as educating staff, nurses, doctors, pharmacists, to recognize when there's a problem and what could potentially go wrong. So as I mentioned, patient safety is our priority number one. This is what regulations and recommendations and guidelines are all written for the safe preparation of these products. So we always want to keep that in mind whenever we do set up an IV room, set up a workflow system, label our products, educate our staff, everything. Specifically, when we're actually in the IV room, we want to make sure that we're working safely. We're not working too quickly that we will cause an error. I always try to train my staff that working too quickly will create errors as well as medication waste, because you'll make the mistake and have to throw the whole batch out. You also have to make sure that the orders are verified correctly. The labeling is not just for the storage of the medication, it's also for the safe administration of the medication. So as we'll see in the presentation, it's not just about compounding, it's also about medication safety. So involve everybody in all this type of education. Many of the problems that I see with compounding are if they're made and they're contaminated. So that's a microbial contamination. Other issues is they may be made cleanly with clean, sterile product, but they're made in sanitary conditions, which would also lead to their contamination and unsafe administration to the patient. They can be made incorrectly, such as the staff did not understand the steps to make it. They had no experience. They could be labeled incorrectly with the incorrect infusion rate, incorrect storage conditions, which may lead to destabilization of the drug. Many different things. This is one of the most famous problems that actually promoted the safe use of medications, as well as the use of the USP chapters. In 2012, it was the NECC, the New England Compounding Center, that led to a major fungal meningitis outbreak in the United States. They were compounding in the state of Massachusetts and shipping this product to many different states, which led to many deaths, as you see, and a lot of harm to patients. And this was essentially from making the product in insanitary conditions and not paying attention to the quality assurance of the product. That would be testing of the product for sterility, testing of the environmental conditions inside the clean room, as well as the hoods, to ensure that they were safe and they were free from fungus. And what happened is these epidurals were contaminated with black mold that led to injections of the black mold into the patients and ultimately 76 deaths. When I talk about medication safety, a great resource is the Institute for Safe Medication Practice. They have regular newsletters which describe errors that are reported by pharmacists, compounders, nurses, and I would definitely recommend that in addition to your compounding service, you also have a medication safety pharmacist, and they would review that newsletter and create education for the staff. The newsletter has drug compounding errors, administration errors, and they also give recommendations to reduce those errors. And you can put that into your own employee education, review it once a week, and recognition of the errors will help the staff become more alert to their own issues. And I always like to tell my students and the new pharmacists I'm teaching is it's better to learn from other errors than your own errors. So make sure you take a look at that. In the hospital, with administration, we see that there's so many errors, and 90% of the hospitalized patients will be receiving IV therapy. So if 61% of those serious and life-threatening errors are related to the IV therapy, you see there's a large possibility of risk here for patients. And we have to work on reducing this risk. In this case, this is related to the administration. So when we see that there's a lot of administration errors, what can we do as pharmacists? We can try to play an active role in the education for nurses. We can make sure that the drug references, the labels, and the IV pump programs are not confusing, and we've standardized as much as possible to reduce those errors. I would also recommend that you have a pharmacist on staff that is the expert on all of the technology that is employed in the hospital. So that is the EMR, the pumps, all of that, and make sure there's regular communication with the IV pharmacist to make sure things are standardized and there's regular communication with new standard concentrations, updates, new preparations, new sizes, the volume of the product. If there's a change from 100 ml to 250 ml, that there's a seamless transition to those in the pumps as well as the EMR. Now with the, back to the compounding room, we can see the sources of errors and where they may occur. This will be related to staff education and staff training. If staff are regularly working in the IV room all day long, every day, they may become complacent or just used to seeing things, and they may assume that something is what they think it is, but it could be labeled differently, a different drug, a different concentration, so they become complacent. So the point there is to ensure that they're always alert and they never review a medication and think that it is the same as it was yesterday. They may have a lack of knowledge, a lack of standardization that comes down to the different concentrations of the products. You should have a chart at your hospital that describes the concentrations, the size, and the volume, and the certain type of fluid that the product would be in, and ensure that those concentrations do not look like each other. There's a number of different errors, especially in pediatric pharmacy, where you can have a 10-fold concentration error given to a patient. If you have an example of 0.2 milligram per ml concentration and a 2 milligram per ml concentration, sometimes the decimal point is not seen, and it leads to a 10-fold error. So if you do design standard concentrations, make sure the numbers are slightly different. So perhaps 1 milligram per ml and 0.2 milligram per ml. Also make sure there's a formal training process and everyone goes through that, and make sure that there are no routine practice deviations, no cutting corners. There should be a designated person that's the expert at the site, which I'll explain shortly, that oversees all of this and make sure that the training is done regularly. It should be done at least annually, and in a diverse way with reading, formal education, didactic education. You will see that soon. This is a very sad error with Emily Jerry, and this relates to working too quickly in the IV room, a little bit of lack of knowledge, and a lot of unfortunate events. And what it was is Sunday morning, a nurse was repeatedly requesting a stat prescription from the pharmacy, and it was etoposide and normal saline 150 ml. And it was supposed to be the last chemotherapy for this patient before she went home. Now, if you do have experience working in an IV room as well as an oncology room, you know that there's no such thing as a stat chemotherapy. But in this case, they felt the pressure and they were trying to get it done. The IV room was busy. This was also a period where there was shortages of normal saline in the market, and the hospital was forced to make their own normal saline using sodium chloride 23.4% mixed with sterile water. Now, when the pharmacist was checking the preparation, he saw the sterile water IV bags. He saw the vials of 23.4%. He assumed that the preparation of etoposide was made with the normal saline, and he proceeded to check it off. It went out to the patient, and shortly after the infusion started, Emily cried out that her head hurt and then went limp, and they were not able to revive Emily back after that. They did a root cause analysis on it, and what happened was that the bag was made with pure 23.4% sodium chloride and etoposide. There was no dilution. The IV room was too busy, and it also happened to be the same day that the normal saline batched bags were prepared. So the pharmacist saw the sterile water bags that would have been used to make normal saline and assumed it was made for this preparation as well, which was the mistake. The technician explained they were overworked. They were also skipping breaks, and it was too busy. And that was essentially it. So if you think about all these issues that go into it, we have to learn and make sure our IV room is being used in a controlled way. that there are limited distractions, that things are easy to understand as far as checking the preparation off. Things are clear with master formulas. The technicians know exactly what needs to be made. And also, this was produced on the weekend on a shift where the staff member would not normally make this preparation. So something else you can consider too is ensuring that chemotherapy is made on regular days and regular periods, and that all staff, if they're going to be making chemotherapy, are educated in those preparations. I have examples of more errors. So we can see here, if you are the pharmacist and the technician hands you this amphotericin B intravitreal injection, is this correct? Would you sign this off as correct? Now, most of us know, if we're pharmacists, that amphotericin B is yellow. So we look at this and, oh, it must be correct, it's yellow, same right drug, it's not clear. Well, if you don't have experience in making preparations for the eye or have seen this before, this could be a problem. You may have signed this off and sent it out to the patient, when in fact, it was supposed to be 5 microgram per 0.1 ml, but it was made as 500 micrograms, so it's 100 times the concentration. You can see on the far right syringe, that is what the correct one looks like. It's a very slight hint of yellow. What happened was, the technician diluted the vial. The first dilution drew up the dose in the syringe and sent it. What needed to happen was a serial dilution of multiple steps to get down to that 5 micrograms per 0.1 ml. And you can read there on the slide the damage to the patient's eye. Now, how would we correct this? Well, we have in our master formula, what is the final preparation? What should it look like? A dark yellow, a light yellow? If you are working at a hospital that makes eye injections, make sure you have some type of an education piece that explains how eye injections are made, what they look like. Pictures are great, as you see here. Education is always going to be the key to promote patient safety. What about this? You've been handed this as the pharmacist, or better yet, if we use the exact case, this is the nurse. The nurse receives this syringe, and she's prepared to give it to the patient. Now, the syringe is going to be wrapped in a light protect bag because it's required for nitroprusside. For adults, it would be presented in a bag. However, for children, you may see it as a syringe because it'll be attached to a syringe pump. Now, the nurse sees this and questions it. You should too, because this is not the correct color of the final preparation of sodium nitroprusside. This means there has been degradation of the drug, likely due to light or some type of a pH or oxidation. The actual drug itself will be pulled out of the syringe in an orange color, as you see, a dark orange. And then once diluted, it'll be a light orange to a pink to a brown. The incorrect color of the final preparation should not be dark orange or bright orange or dark brown, or in this case, as you see, blue. And that's all related to light decomposition. So this would be part of your master formula, but remember, I also said who was catching this was the nurse. So as pharmacists and as drug experts, we have the opportunity in the hospital to educate nurses as well as physicians. So you should offer to have nurse compounded drug and administration of drugs class at least once a year, as well as if a new hire nurse, to explain how you make these preparations, what do they look like, and you may, if you want, you can even have on the label what the final preparation should look like on special case syringes like this. Report if syringe is blue, green, or red, things like that. And they should also be inspecting the preparation before they give it to the patient. So we see a little bit of the importance here about education and compounding errors, but let's take a look at the design of a sterile compounding service and what that looks like. You first need to start with a designated person, and this role is described in the different USP chapters. And briefly put, they would oversee the entire compounding operation. They would have to meet a certain level of competency, and you can look at national guidelines for that. There are new certifications now from the Board of Pharmacy Specialties for board certified sterile compounding pharmacists. You can also go to ASHP for a sterile compounding certificate. Those are great ways to have very detailed education on compounding. And you can see all the other roles listed. They should be experts, not just in the guidelines as well as the regulatory compliance that 797 would describe, but also experts in the art of compounding. how do you make this preparation? Experts in drug stability and where to look, all that. And once they're the expert, then they are the key person to create the education for the rest of the staff, from pharmacy to nursing to physicians. But where do you start? It's, like I said, there is no actual drug or reference to go to for this. I mean, we can look at regulations, in best practice. We have to know a little bit about medication safety and the basics, art and science of compounding. So what books do we go? Where do we start? It is a lot for a person to handle, but there's always other experts to ask, and I'll explain some references later. We can start with the USP chapters. Even though these are the 2019 versions that are temporarily on hold, they are organized extremely well and have great specific descriptions of what the designated role of the pharmacist should be. And as that designated person, you would be responsible for the compounding for sterile preparations, non-sterile preparations, as well as the protection of staff from hazardous drugs. You can organize your whole designated compounding or your sterile compounding service in a format like this. Just remember that patient safety is the #1 goal, so I put that in the middle. And education from staff is, I would say, the most important to trying to reduce errors. That's why I put that first. So we'll look at employee education, how to set that up, the quality assurance, basics of that, regulatory compliance. That would be looking at recommendations that also following local and national and international standards, what the compounding process would look like, and then a little bit of employee safety. So with that education, you want to make sure that your education actually matches your operation. Do not go buy a book that says compounding education and just have them read that, because most of that may not make sense. You should have it tailored specifically to your site. If you're mostly making eye preparations, make sure that your education focuses on that. If it's just simple preparations, 1 vial to a bag, make sure you focus on that. Same thing with chemotherapy. For every individual role that is in your compounding operation, or chemotherapy or whatnot, you should have specific education that would meet all of those expectations of that person's role in the hospital. So it needs to be as advanced as the work that they are expected to do. Make sure it is direct and hands-on, so they're under direct observation of yourself as a designated person or as a supervisor. Certainly incorporate video. I like making videos and putting those on YouTube because I'm not always present in my pharmacy. However, they can review that as part of their education plan, as well as take an exam. The exam should be written and verbal. Of course, you would directly observe their competency as far as the compounding, make sure the hand is being held correctly to not obstruct the first air that is coming out of the hood. Regularly evaluate. I say, the requirements from 797 right now, the minimum requirements are once a year, but you can do it however often as you want or feel the need for, depending on what your observations of the staff are. Make sure all of the education is documented and that you are keeping track of everybody's education to make sure it's correct. And then it comes down to testing of the compounding staff. This would be media fills and fingertip tests as described in USP 797. I put together a image for you just to get an example of what this would look like. Most hospitals will probably have one single IV room with one type of hood, and the LAFW will be that laminar airflow workspace. So if you have a new staff hire, you would have to do 3 initial tests with the fingertip test, and that would be putting on all of your garb. That's the mask, the hair covers, the shoe covers, and the gown in the correct order. And then you would, after they put their sterile gloves on in the sterile method, then you would test their fingertips on agar plates. And you would do that once a day on 3 separate days. In addition to that, in the hood, you would have them do a media fill test, and that is just a sample test with this has agar, liquid agar inside the bag, as well as some vials and with needles and syringes. However complicated your products are being made, that is how your media fill test should match. You should not be doing complicated TPNs and then have a 1 vial to a 1 bag test. You would have to have a practice TPN of some form with some media in it, and that would simulate your compounding process. After you do that media fill test, immediately after, before they even clean up, then you would have them sample with their gloves, left and right hand, on the media plates. And that would test to see if they had cleaned everything correctly. If you have different hoods, such as a CAI or a CACI, which are compounding aseptic isolators, or a biological safety cabinet for the BSc if they're doing chemotherapy. Then, because that is a different compounding environment with different directions of airflow, you would have to do the media film fingertip test there as well. Make sure you monitor the quality of your products. So you're doing the appropriate inspection of the finished product. That's looking for precipitations or rubber stopper core fragments. You also have to do at least annually potency and sterility checks of some preparations in your operation, and that's described in USP 797 how you do that. Make sure that at least on a daily basis, you as the supervisor are monitoring the conditions of the clean room. So that's temperatures, the air pressure differentials between the rooms, the air changes per hour in the rooms, and the humidity. Make sure you do certification of the clean room at least every 6 months along with the equipment, and that makes sure that everything is operating and performing correctly, as well as sampling of the air itself to make sure that it has the minimum amount of particles to meet certain air conditions, ISO 5, ISO 7, ISO 8, that type of thing. For the temperatures, I threw a chart here, which I'm not going to really go over. This is more of a reference for the those that are getting their program started. You just make sure that you monitor the incubators daily if you have media in them, monitoring refrigerators and freezers. Just note that you make sure you must store your product as it is described by the manufacturer. So if USP 797 says a freezer range of -25 to -10 Celsius, you should also check the product to make sure that it should be stored at that temperature. In this case, frozen products from Baxter would require -30 to -20 Celsius. Also with the ISO levels, the classified air in the different clean room, anteroom, and storage room, within those areas, they also have controlled temperatures. So you want to have at least 18 to 20 degrees Celsius. Now the reason for that, you want to have it colder as possible so that it's comfortable for the staff, because you keep in mind, what are they doing? They're putting on a gown, they're putting on a hat and a mask and gloves and shoe covers, and sometimes they may be wearing a full suit, so they're going to get hot. Now what happens when we get hot? We start to sweat. As we sweat, we throw off a whole lot more bacteria than usual, and then maybe contaminating the room. So we want to make sure the staff are comfortable once they have all of that garb on and they're not sweating. When it comes down to air pressures, this is essentially to ensure that the bacteria are kept out, so you have a higher pressure in the clean room as it flows out into the anteroom, and it keeps the dirty air out. When it comes to hazardous compounding, that room would be negative pressure, but the anteroom would have a positive pressure with cleaner air, and that would supply the clean air into the clean room. I'll show you a picture in just a moment. With humidity, it's not so much required in the USP 797 version 2008. It's highly recommended in the 2019 version, which is not official yet. But the importance of humidity is that if you have a high humidity, that will lead to growth of bacteria and molds in the clean room. If you have too low, it may lead to some malfunctions in electronic equipment, especially with static electric discharge. So you want to keep it in a safe range between 30 and 60. I've seen some ranges that go as low as 20, which are appropriate. An example of a clean room with a shared anteroom, I listed where the positive and negative pressures would be, as well as air changes per hour if you're going to have a fully compliant functioning compounding suite. And there's different methods to put on your sterile garb as you step over those lines of demarcations, which I will not talk about now. But when we look at the clean room design, we do have to do testing for viable sampling. That would be testing the air is clean, as well as the surfaces are clean, and we're cleaning them daily. So where might we test this air for viable air sampling? We might choose something like this, and this would be your role as a designated person. We would put a sampler inside the hoods as well as in the areas in the room, and the air is going to pull it, or the volumetric air sample will impact the air as it pulls it down into an agar plate. And then you would take the agar plate and put it into an incubator and see what grows out. And if you have a lot of bacteria growing, that will indicate that there is a problem and your air is not clean. You can have a few bacterial colony forming units here and there. We certainly don't want any fungus growing, but it would be expected to see a fungus every so often in the anteroom on the dirty side, because the anteroom is where dirty becomes clean. As we wash up, we put our gowns on, so it wouldn't be unexpected. Surface sampling, we might want to test these areas, high touch areas, maybe a corner of the sink. If you have doorknobs, you may want to do that. Surfaces inside the hood to make sure those are cleaned appropriately. Perhaps the handle on the chemo fridge. Many different places. It's your best judgment as a designated person. Just make sure they're high touch areas. You can reference these. These are from USP 797, the 2008 version. This would be the amount of acceptable level versus unacceptable level in the clean room. So if I start with the orange table for viable air sampling, we would be allowed essentially just one bacterial colony forming unit inside the hood. That's the ISO 5 air. We don't want any more than that. One may be possible, but make sure you monitor that. Anything more than that will be an action level and you have to take steps. ISO 7 air would be the clean room air itself, and you can have up to 10 before it's a problem, and up to 100 in the anteroom, which is the ISO class 8 air. When it comes to the surface sampling, there's a little bit more that are allowed in the hood, and we have up to 5 that's allowed in the clean room itself, the ISO 7 air, and then where I have in the yellow box, in the 2008 version, it was of USP 797, we were allowed up to 100 colony forming units in the anteroom. However, that'll drop down to 50 in the 2019 version, which is not official. So example plates. Now, depending on your surface or your air sampler, it can accommodate different types of plates. So on the left, this is a smaller plate as a contact plate. And you see, this is the colonies that I drew on it. There's 1, 2, 3, 4, 5. So this would be appropriate for an anteroom, perhaps a clean room, but certainly not a hood. So on the right side is tryptic soy agar with a sheep's blood as a feed source for the bacteria. You can see here that this would likely fail air samples. So this wouldn't be an issue. This is what a mold would look like. There's many different species of mold, of course, so they would all have different morphologies, but you can tell here it's raised. This grew quite quickly. It's growing on tryptic soy agar. You can also use malt extract dextrose agar, many different types of agar as well, that would promote fungal growth. This will be an example of a completely failed test. This will be very bad, and you can see it's so bad that the location of the colonies on a plate are actually matching the intake holes of the air sampler. And you can take a look closer and you can see there's some interesting morphology there, perhaps some fungus and some molds and amongst the bacteria. So this would be something where you would want to stop compounding and investigate this. Cleaning frequencies. This is a clip from the 2019 version of USP 797. I'm not going to walk through this completely because I have some slides in here that are for reference only. Just know that you have to clean certain areas on a daily basis as well as a monthly basis. Where monthly is usually going to be control of spores using a sporicide, and daily would be all the actual work surfaces. And keep in mind, you're also cleaning at least every 30 minutes and between batches when you're compounding inside the hood. How might you set this up? Well, the previous chart was just explaining the frequency, but you have to have some type of an education or a poster for your staff to go by. And this is where you would insert your cleaning chemicals and make sure they're used appropriately in the right order and how long they would be there. So in the case of like a Tex-Q, which is a quaternary ammonia, if you would look at the label and it says you need to have it on the surface for at least 10 minutes to have a killing effect, then it needs to be 10 minutes. Paradox RTU, which is nice, it kills everything, viruses, fungus, spores, and even decontaminates chemotherapy surfaces. That just needs to be on for 3 minutes. So you want to make an education piece like this for staff and make sure they're following everything in your policies and procedures. As far as cleaning the hood, there's also a certain method we would do that. You would start at the filter at the top and then work on the back of the hood, then the two sides, and then the floor of the hood, and then finally the glass. You can use your hand or you can use a tool. The tool is very easy to get in those tight places, and make sure if it does have an under tray, you'd at least clean that once a week. And when I mentioned about cleaning chemicals, that would be an order something like using sterile water to dissolve any drug residues that are crystallized there, if any are present. Then you can use your cleaning agent, and then finally sterile alcohol to wipe up any residues of the cleaning agent. As far as the regulatory compliance, make sure you have detailed policies and procedures for everything that you're going to be doing in the clean room, and this will cut down on errors. Make sure that you're cleaning and monitoring everything. And then also following any additional regulations that could be there, and then local and national. When it comes down to the master formulas, I won't go through this, but I did provide an example for those that are going to be creating these. It's a description that's very detailed of all aspects of the compounding process, from the ingredients to the beyond use state selection, the equipment you will use, any specific process, dispensing notes, labeling, and quality reviews, and what is the resulting color and what it should look like. Beyond use dates, this would be for under USP 797 and how we would set that if it is a 1 vial to 1 bag example, or if it's a TPN, that might be medium risk, and this would be the storage conditions that you would have before you can start that infusion. On the 2019 version of 797, I highlighted the part that would make sense to us in the hospital compounding program. So that would be aseptically processed compounded sterile preparations. We would not be doing a sterility test. We would be using sterile products. And under this guideline, we would have had 4 days of room temperature or 10 days refrigerated or 45 days frozen that you could actually keep the product before that you would have to throw it out. Now, standardized preparations, make sure that it's clearly written on the master formulas how you will dilute it. It will be in dextrose, normal saline, what solution, what concentration, if it requires light protection, if it needs PVC or specifically non-PVC bags and infusion lines. Many chemotherapies are like that. What type of filters must be used in compounding or administration, and if it's supposed to be an IV piggy bag or syringe. Specifically, we would never send vinca alkaloids in syringe because there have been many errors on that, so always send those in IV piggybacks. For the compounding record, this is recording everyone who was involved in the preparation, as well as final notes, and this is in lot numbers and manufacturers. Checking the final product, you see we have an issue. If there is a white background, we can see a rubber stopper, but if it's a black background, we may not see a black rubber stopper, but we could see some white drug precipitates. So make sure you check it on two different backgrounds. We did run a short study last year, or this year, for how our staff could actually see some stopper cores. We did 5 bags that had stopper cores amongst many other bags, and 28 members completed the survey. Most were pharmacists, and then 12 were technicians. And what were the results is at least everybody saw 1 fragment. On 2 fragments, everybody saw that 2. 7 people only caught 3 fragments. 14 people caught 4 fragments, and only 8 caught all 5 fragments. So that means 71% of the staff did not identify all 5 of the stopper cores. Now, what would that mean is it may go out and be infused to the patient. So you may ask yourself, do I need a filter to infuse everything? What should I do? Well, it means that you should educate your staff to appropriately compound using the right size needles, that they're doing the right quality reviews between the light and dark background. And if there's still going to be issues, then you can convert to using all filters. Make sure that you are educating staff on hazardous drugs, a safe work environment, safe working practices, and how to use an eye washer where that would be. This is a relatively quick section about the resources available. Start with 797 and the other chapters. You can look at your professional societies, join IVPN Network, which is a mailing list of many different compounding pharmacists and those that do parenteral nutrition. There's many different other societies you can join. You can also work on getting a certificate. There's also courses and workshops from experts. I said Board of Pharmacy Specialties was a good one too, so take a look at that. Many different guidelines, from the USP to NIOSH for hazardous drugs to ISMP to all the different guidelines from ASHP. And they have everything from ophthalmic products to compounded sterile preparations. It's great. Many different websites. Take a look at these. They all have education materials. So if you don't want to write your own, you can look at theirs to see if you want to assign those to your staff. There's also many different drug apps. Lexicomp, UpToDate, those will have compounding directions, as well as micromedics and clinical pharmacology. Trissels comes as an app as well as a book. But now, what books do you use? I'll flip through these quickly, but what's the best reference? I often get asked that. You know, I like Trissels and Bing's Extended Stability. King Guide also organizes a bunch of other drug stability papers. Many different journals we can do. So this one is the #1 we probably hear about, Trissels. You can order the book. It's going to organize everything on stability and also drug compatibility studies. There's Extended Stability from Bing's, and it's the same data, but it's organized a little bit more cleanly and easier to see charts. This one, it is also Trissels, but it's also non-sterile preparations and many different monographs. A lot more information you might be able to find here versus online. It's very easy reading. This is Lexicomp, the book form. What happens if your internet goes out or you want to take this to an emergency? You don't want to be checking your phone when there's a pediatric emergency and you have to figure out how to compound something. It's better to just have the book there. AHFS drugs is great. It also has extensive off-label uses and related drug dosings that you might not find in Lexicomp. Pediatric injectable drugs is excellent too, because it's the same drug information you might find in other resources. However, it is curated by pediatric pharmacists through the filter of their own education. Pediatric oral formulations, also oral and geriatric. This one's great for a handbook of our enteral feeding tubes. And with all those references and everything I've discussed in the past, what I want you to take away from this is make sure you have a dedicated compounding service. It's needed to standardize all the processes in the hospital IV room to promote patient safety. Your trained staff must follow standard practice that will ensure the patient safety and the staff safety, and then they should become the experts in drug compounding. And then each aspect of the USP guidelines is written with the ultimate goal of ensuring patient safety, so make sure you follow that. Here's the references and my presenter information.
Thank you, Michael, for your wonderful presentation. Dr. Aisha, we can go ahead with our next speaker, please.
Bismillahirrahmanirrahim. Assalamu alaikum. I am Aisha Khan. I am Aisha Khan, and I warmly welcome you all on behalf of Giving Back to Pharmacy in Pakistan in the 7th session of the first virtual International Pharmacy Conference of Pakistan. The speaker of the session today is Dr. Muhammad Rehan Khan. He is currently working as an assistant manager clinical pharmacy in Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore. He has a total experience of 10 years in hospital pharmacy. He has worked at Qaid Azam International Hospital and Ubaid Noor Hospital, Miawali. His specialty is infectious diseases, and that includes a wide variety of tasks for effective implementation and promotion of antimicrobial stewardship program. The topic of his presentation today is role of pharmacists in infection control from training to prophylaxis. Handing over to Dr. Muhammad Rehan Khan.
Assalamu alaikum. Thank you very much, Aisha, for the introduction. Juma Mubarak to everyone, and I welcome you all for the first ever session by the conference arranged by the Giving Back to Pharmacy in Pakistan. Today, the topic, the role of pharmacist in infection control measures. I will try my level best to keep things as much simple as I can so that the mass can understand, especially the focus would be the students and those who are new in the pharmacy practice. My disclosure, I have no disclosure thing. The topic is infection control. एक saying है कि it's important, prevention is better than the cure. It is important to prevent something rather than it happens and we are trying to cure it. COVID-19 has taught us this lesson. Wherever in the world आप दुनिया में जहाँ भी देख लें, इस वक्त फोकस किस चीज़ पे है कि प्रिवेंशन पे है कि किसी तरीके से कोविड को प्रिवेंट किया जा सके रादर देन कि आप इन्फेक्टेड हो जाएं और उसके बाद फिर आपको ट्रीट किया जाए, उसकी कॉम्प्लिकेशंस, उसकी एक्सपेंडिचर कॉस्ट, ये सारी चीज़ें डिफरेंट होती हैं, लेकिन इम्पॉर्टेंट पार्ट है इन्फेक्शन को कंट्रोल करना. तो वही आज बेसिक टॉपिक था जो मुझे असाइन किया था कि इन्फेक्शन कंट्रोल, और इस इन्फेक्शन कंट्रोल के अंदर फार्मासिस्ट का रोल. फार्मासिस्ट, स्पेशली द प्रैक्टिसिंग फार्मासिस्ट, हैज़ वेरी important role to play whenever it comes in any and every setting to promote the role. Well, the infection control prevents or stops the spread of infection in healthcare settings. The important thing, prevents and stops the spread of infection in healthcare setting. It may be anywhere, any hospital, any community setting where there is patients or we are dealing with the patients or dispensing medication or any such thing. This includes an overview of how infection spreads, the ways to prevent the spread of infection, and more detailed recommendations by the type of the healthcare setting. Again, definition के अंदर ये CDC की definition मैंने pick की है. हाउ टू प्रिवेंट इन्फेक्शन. जिस तरह कोविड-19 के अंदर हमें कहा गया है कि आप मास्क यूज़ करें, आप हैंड हाइजीन हैंड सैनिटाइजर्स यूज़ करें, इसके अलावा हैंड रब, ये जितनी हैंड वॉश प्रैक्टिसेस और डिस्टेंस मेंटेन करना, ये सारी प्रैक्टिसेस क्या चीज़ें हैं, हाउ टू प्रिवेंट द स्प्रेड. एट द सेम टाइम हमें ये भी गाइड किया गया कि ये फैलता किस तरह. इट यूजेस बेसिकली हम जब खांसते हैं, बोलते हैं, तो हमारे इससे फैलता है कोविड, और उसमें ये होता है कि जी एयर के थ्रू इसकी ट्रांसमिशन होती है. दैट्स वाई हमने फेस मास्क यूज़ करने हैं, इसके अलावा डिस्टेंस मेंटेन करना है. तो ये सारी चीज़ें एक्चुअली कोविड-19 ने हमें सिखाई हैं कि इन्फेक्शन प्रिवेंशन का कितनी इंपॉर्टेंस है, स्पेशली किसी भी हॉस्पिटल के अंदर. अब हॉस्पिटल से निकल के कम्युनिटी के अंदर भी इसकी कितनी इंपॉर्टेंस है. इसी वजह से हॉस्पिटल फार्मासिस्ट का भी रोल है और कम्युनिटी फार्मासिस्ट का भी रोल है. अब इंपॉर्टेंट चीज आ जाती है इन्फेक्शन कंट्रोल मेजर्स. इंपॉर्टेंस ऑफ इन्फेक्शन कंट्रोल मेजर्स फॉर हॉस्पिटल एंड कम्युनिटी. जिस तरह मैंने अभी बताया है कि सबसे इंपॉर्टेंट चीज है कि हॉस्पिटल के अंदर, स्पेशली जब भी पेशेंट हॉस्पिटल के अंदर आता है, वहां पे होता है हॉस्पिटल एक्वायर्ड इन्फेक्शंस को प्रिवेंट कर कि पेशेंट को किसी तरीके से भी हॉस्पिटल एक्वायर्ड इन्फेक्शंस, क्योंकि जो हॉस्पिटल के बग्स होते हैं वो ज्यादा रेजिस्टेंट होते हैं रादर देन दो दे आर इन द कम्युनिटी. एट द सेम टाइम अगेन आपने देखा होगा कि जब ये कोविड इन्फेक्शन है तो उसमें आपने आइसोलेशन वार्ड्स देखे हैं, उसमें प्रॉपर पीपीईज देखे हैं, डिफरेंट गाइडलाइंस आपने देखी हैं. क्यों? ताकि वो जो पेशेंट इन्फेक्टेड होके आया है उसकी इन्फेक्शन दूसरे हेल्थ केयर प्रोफेशनल्स या दूसरे पेशेंट्स या उनके अटेंडेंट्स तक ना पहुंचे, ताकि ये स्प्रेड ना हो. तो ये एक्चुअली इंपॉर्टेंट जिस तरह कह सकते हैं कि पर्पस है इन्फेक्शन कंट्रोल मेजर्स का, इवन इन हॉस्पिटल एंड कम्युनिटी. इसके अलावा डिफरेंट इस पे आगे थोड़ा सा होती हैं कि आपकी डिफरेंट गाइडलाइंस एंड स्टैंडर्ड्स रिगार्डिंग इन्फेक्शन कंट्रोल. फॉर एग्जांपल जेसीआई है, जेसीआई जॉइंट मिशन, हॉस्पिटल के अंदर आपने क्या क्या मेजर्स लेने हैं, आपने आइसोलेशन रूम्स को किस तरह मेंटेन करना है, पेशेंट स्क्रीनिंग किस तरह करनी है, ये सारे जेसीआई आपको रिकमेंडेशन दे रहे हैं. आपने आपके स्टाफ ने हैंड हाइजीन मेंटेन कर रहा है नहीं कर रहा. इसके अलावा यूएसपी 797 ये मतलब फार्मेसी की तरफ से है, फार्मेसी के लिए है कि आप सबसे इंपॉर्टेंट चीज ये है कि जो भी प्रोडक्ट बन रही है वो फार्मेसी, स्पेशली जब स्टीराइल कंपाउंडिंग हो रही है या जो भी इवन कंपाउंड डिस्पेंसिंग हम कर रहे हैं कंपाउंड करके, उसको स्टीराइल होना चाहिए. सबसे मेरे से पहली प्रेजेंटेशन थी, इसमें बड़ा डिटेल्ड एक ओवरव्यू आपको दिया गया कि हाउ वी कैन टेक डिफरेंट मेजर्स टू इंश्योर दैट द प्रोडक्ट दैट वी आर कंपाउंडिंग इन आवर फार्मेसी aseptic area, they are sterile, so that there is no infection from those प्रोडक्ट्स. द कंपाउंडिंग जो हम कर रहे हैं स्टीराइल है, सो दैट पेशेंट को उससे कोई इन्फेक्शन नहीं हो रही है. अगर आपकी फॉर एग्जांपल आईवी प्रिपरेशन, उसके अंदर थोड़ी सी भी कंटेमिनेशन है, दैट कंटेमिनेट विल गो डायरेक्टली इनटू द ब्लड. फॉर एग्जांपल मैं इसकी एग्जांपल सिंपल देता हूँ, टीपीएन जो टीपीएन प्रिपेयर करके दे रहे होते हैं उसमें हाई रिस्क के जो लिपिड है उसके अंदर फंगस ग्रो कर सकती है, कैंडिडा डिफरेंट किस्म के, फॉर एग्जांपल कैंडिडा ऑरियस ग्रो कर सकता है. तो अगर आपने वो प्रॉपर उसके जो मेजर्स हैं नहीं लिए हैं तो क्या होगा कि टीपीएन के थ्रू पेशेंट जो एक लाइफ सेविंग मेडिकेशन पेशेंट के लिए जा रही थी वो एक पेशेंट के लिए लाइफ थ्रेटनिंग हो जाती है बिकॉज ऑफ द इन्फेक्शन. Third thing, the dependence of the antibiotic stewardship program on infection control measures. Thing is, antibiotic stewardship program deals with the rationalization of the use of the antibiotics. तो उससे ज्यादा बेसिकली जितने भी इसके टूल्स वगैरह हम यूज कर रहे होते हैं उसका टारगेट क्या होता है कि आपने रैशनलाइज करना है यूज को, आपने कंजम्पशन को कंट्रोल करना है. बट अगर पेशेंट को इन्फेक्शन हो रही है तो हाउ वुड यू कंट्रोल द कंजम्पशन. मैं आगे से कुछ एग्जांपल भी शेयर करूंगा. तो डिफरेंट वेज होंगे आपने इन्फेक्शन को प्रिवेंट करना है सो दैट आपका जो एंटीबायोटिक्स का यूज है वो कंट्रोल के अंदर है. स्पेशली अगर तो हॉस्पिटल रिक्वायर्ड इन्फेक्शन हो रही है तो उस केस में एमडीआर ज्यादा होंगे और आपकी रिस्ट्रिक्टेड एंटीबायोटिक्स ज्यादा यूज होंगी, आपका रेजिस्टेंस का पैटर्न इंक्रीज होगा. तो इंपॉर्टेंट क्या चीज है कि आप इन्फेक्शन होने ही ना दें, इन्फेक्शन स्प्रेड को कंट्रोल करें, वट एवर नेसेसरी मेजर्स आप लें और इन्फेक्शन को कंट्रोल करें. द इंपॉर्टेंट पार्ट द रोल ऑफ फार्मासिस्ट इन्फेक्शन प्रिवेंशन एंड कंट्रोल एंड कम्युनिटी. आगे इस चीज से मैं काफी फोकस करूंगा कि फार्मासिस्ट का रोल ना सिर्फ हॉस्पिटल के अंदर है बल्कि कम्युनिटी के अंदर भी है और किस तरह अपना रोल फार्मासिस्ट प्ले कर सकता है इस चीज को कंट्रोल करने के अंदर. सबसे पहले तो फार्मासिस्ट का रोल फार्मेसी के अंदर क्या है. मैंने जिस तरह पहले बताया, क्वालिटी कंट्रोल प्रोग्राम्स अपने फार्मेसी के अंदर अडॉप्ट करने हैं टू प्रिवेंट कंटेमिनेशन ऑफ मेडिकेशंस दैट आर प्रिपेयर्ड एंड डिस्पेंस्ड बाय द फार्मेसी. अब डिफरेंट वाइड वैरायटी ऑफ बेसिकली प्रिपरेशंस हम प्रिपेयर कर रहे हैं जिसके अंदर हम फॉर एग्जांपल मैं अपने सेटअप की देख रहा हूँ, कीमो प्रिपेयर कर रहे हैं, एंटीबायोटिक्स प्रिपेयर कर रहे हैं, टीपीएन प्रिपेयर कर रहे हैं, डिफरेंट किस्म की हाइड्रेशन, पोटाशियम बोलोसिस, मैग्नीशियम बोलोसिस, बोलोस मैग्नीशियम हाइड्रेशन जरा सारे प्रिपेयर कर रहे हैं. इसके अलावा हाइपरटोनिक्स लाइन वट एवर वी आर प्रिपेयरिंग जो कि पेशेंट को एडमिनिस्टर होनी है. अगर उसमें कंटेमिनेशन है तो वी आर इंडेंजरिंग द लाइफ ऑफ द पेशेंट. So it is امپورٹنٹ کہ آپ کا جو اسٹاف جو اس ایریا میں کام کر رہا ہے وہ ان سارے اسٹینڈرڈس کے ساتھ جو ساری پریکاشنز ان کے ساتھ کمپلائی کر رہا ہو. تو ہاؤ you have to ensure this through proper audits, proper checks, whatever measures you take. اپنے گائیڈ لائنس موجود ہیں جس طرح پہلے بھی ایکسپلین کی گئی ہیں, وہ آپ نے میک شیور کرنی ہے کہ وہ آپ کے اس میں اڈاپٹ کی گئی ہیں. فار ایگزامپل USP 797 اس کی گائیڈ لائنس ساری موجود ہیں, آپ نے ان کو کمپلائنس امپورٹنٹ ہے کہ ہمارے جو سیٹ اپ ہیں اس کے اندر اس کی کمپلائنس ہو, سو دیٹ to ensure the sterility, the hygiene and everything. جتنے باقی ٹیسٹ وغیرہ ہیں, فار ایگزامپل twice weekly, twice monthly, twice yearly اور quarterly آپ نے اپنی سیمپلنگ کرنی ہے کہ آپ کے پاس کنٹامینیشن تو نہیں ہے. اس کے علاوہ باقی جتنے میجرز ہیں آپ نے اپنے لیمینار فلو ہوڈز ہیں ان کا چیک کرنا ہے کہ ان کی لائف ٹھیک ہے, کیا وہ فلٹرز ٹھیک کام کر رہے ہیں, بایو میڈیکلز ان کے ساتھ کوآرڈینیٹ کر کے, سو دیٹ دے آر ریپلیسڈ. اس کے علاوہ جو فریج, یہ جتنی بھی آئٹمس ہیں اس میں کوئی ڈسٹ تو نہیں ہے, کوئی کنٹامینیٹ تو نہیں ہے. آپ کے سنکس وغیرہ کو آپ نے دیکھنا ہے وہاں پہ کوئی, کیونکہ یہاں پہ بھی آپ جس طرح کہتے ہیں موئسچر, یہ چیزیں ہیں وہاں پہ فنگس یا وائرل انفیکشنز کی گروتھ کا رسک ہوتا ہے. تھرڈ از انوائرمنٹل کنٹرول, کلچر بائنولی انشورنگ کوالٹی فلٹرز. اپنے نیگیٹو یا پازیٹیو پریشر رومس مینٹین کرنے سو دیٹ پارٹیکل یا جو بھی بیکٹیریل ڈسٹ ہے وہ ایئر میں ہینگ نہ ہو اور بیسیکلی آپ کی پروڈکٹ جو ہے اس کو کنٹامینیٹ نہ کرے. اس کے علاوہ صرف یہ بھی نہیں, یہ تو آپ کی میں نے اسٹیرائل لے رکھی ہے, آپ کی جو فارمیسی ہے, جنرل جو OPD فارمیسی ہے, کمیونٹی فارمیسی ہے, وہاں پہ جو آپ کی پروڈکٹس پڑی ہوئی ہیں وہاں پہ بھی آپ انشور کریں کہ آپ نے ہائیجین کا پراپر کیئر کی ہوئی ہے, کہ آپ کی جو شیلفس ہیں وہ کلین ہونی چاہیے, جو آپ کی میڈیسن پڑی ہوئی ہیں وہ کلین ہونی چاہیے. اس کے علاوہ جب آپ ٹیبلٹ فلنگ کر رہے ہیں, فار ایگزامپل کچھ تو ٹیبلٹ ہوتی ہیں کہ جی ٹھیک ہے جی آپ جس میں اوپن پلز دینی ہے, فار ایگزامپل آپ نے پریڈنیسلون ہو گئی, ڈیکسامیتھاسون ہو گئی, یہ اس قسم کی جب آپ پلز دے رہے ہوتے ہیں تو اس میں تو پیشنٹ سارا وہ 1000 کا آئی تھنک سو پیک ہوتا ہے, تو 1000 تو نہیں لے گا, اس کو کچھ نمبر چاہیے ہوتا ہے. تو جب وہ پلز نکال رہے ہیں اور کسی زپر وغیرہ میں ڈال رہے ہیں تو آپ انشور کریں کہ آپ نے کوئی اس کو کنٹامینیٹ نہیں کرنا, ہائیجین کے جتنے میجرز ہیں وہ سارے لینے ہیں, سو دیٹ پیشنٹ از گونا ٹیک. اور جو پیشنٹ اس نے انجسٹ کرنا ہے ڈائریکٹ پیشنٹ کی باڈی میں, اگر اس میں یہاں پہ اپنی کنٹامینیشن کر دی ہے تو یو آر انڈینجرنگ دا لائف آف یور پیشنٹ. سو یہ صرف ایسیپٹک پہ نہیں آتا بلکہ OPD یا جہاں پہ بھی آپ کام کر رہے ہیں وہاں پہ بھی یہ سارے میجرز اپلائی ہوتے ہیں آپ پہ. نیکسٹ یہ تو اپنے فارمیسی پہ, اس کے علاوہ یہ ہے کہ اب فارمیسی سے نکل کے آگے فارماسسٹ کیا کر سکتا ہے, ہاؤ فارماسسٹ کین انشور انفیکشن کنٹرول ان دا ہاسپٹل اور ان دا کمیونٹی. میں سب سے پہلے ہاسپٹل کا, فارماسسٹ کین بی پارٹ آف مینی ملٹی ڈسپلینری ٹیمس, فار ایگزامپل انفیکشن کنٹرول کمیٹی, یا اس کو اینٹی بایوٹک اسٹوورڈشپ کمیٹی بھی آپ کہہ سکتے ہیں, جو نام بھی آپ اس کو دے لیں. اس میں کیا ہوتا ہے کہ اینٹی بایوٹک اسٹوورڈشپ پروگرام, اینٹی بایوٹک اسٹوورڈشپ پروگرام ایک براڈ ٹرم ہے جس کے اندر ہم کیا کہتے ہیں کہ ریشنلائزیشن آف یوز آف اینٹی بایوٹکس. اس کے اندر یہ بھی ہوتا ہے کہ آپ کی irrational تو نہیں ہو سکتی ہیں, کیونکہ irrational use of antibiotics leads to infections, MDR infections, adverse drugs for the patients, different things جو آپ basically stewardship program کے through control کرنا ہوتا ہے. ویکسینیشن پروگرام فار ایگزامپل آپ فارماسسٹ ہیں, آپ کو انشور کرنا چاہیے کہ آپ کی ویکسینیشن, فار ایگزامپل اس میں فلو ویکسین ہے, فلو ویکسین سیزنل اویلیبل کرانا, اور اس کے بعد انشور کرانا کہ جتنے بھی اسٹاف آپ کے اسپیشلی فارمیسی اسٹاف ہیں یا جو بھی ہاسپٹل اسٹاف ہیں ان سب کو ایڈمنسٹر کی جاتی ہے, سو دیٹ اگر آپ کا اسٹاف فلو کے ساتھ ہے تو اس سے کیا ہوگا کہ رسک کس کو ہے, پیشنٹ کو. ایٹ دی اینڈ پیشنٹ سیفٹی از امپورٹنٹ, اسٹاف سیفٹی keeping in mind the patient safety. اسی طرح آپ کی جو باقی ویکسینز ہوتی ہیں, فار ایگزامپل ہیپیٹائٹس بی ویکسین, آپ کی اسٹاف کے جتنے ویکسینیشن ہیں وہ سارا آپ نے انشور کرنا ہوتا ہے. گائیڈ لائنز اور پالیسی ڈیولپمنٹ, میں اس میں سمپل ایک چھوٹی سی بات اس میں کر دیتا ہوں کہ فارماسسٹ کا کتنا امپورٹنٹ رول ہے. میں ایگزامپل ایک دیتا ہوں, فار ایگزامپل ہمارے ہاسپٹل کے اندر ہم آبزرو کر رہے تھے کہ سرجیکل سائڈ انفیکشنز انکریز ہو رہی تھی. I being the part of the infection control committee was reviewing things. What we found that there was inappropriate dose of perioperative antibiotics. For example, Spazolin was administered 1 gram in place of 2 gram. گائیڈ لائنس جو ASHP یا ڈفرینٹ گائیڈ لائنس ہیں آپ اس میں ریویو کریں تو اس میں 2 گرام ڈوز ہے پیری آپریٹو, اور اس کے بعد ایوری 4 آورلی اگر پیشنٹ اس سے زیادہ ہے تو آپ نے اس کو ری ڈوز کرنا ہے. تو یہ کچھ چیزیں تھیں ہم نے آبزرو کی, ہم نے اپنی کمیٹی کے سامنے پریزنٹ کی. وہاں پہ ہمیں ایک دیا گیا تھا کہ ہم اپنے ہاسپٹل کی گائیڈ لائنس ڈیولپ کریں. ہم نے کیا کیا کہ اپنے ہاسپٹل کی پیری آپریٹو پری پوسٹ سرجیکل گائیڈ لائنس ڈیولپ کی اور اس کو انشور کیا کہ ہماری جو جتنے بھی سرجنز ہیں, جتنی بھی سرجریز ہو رہے ہیں اس کے ساتھ کمپلائنس جو کر رہے ہیں. ایک تو تھا پری آڈٹ, اب گائیڈ لائنس بن گئی ہیں, اس کے بعد پوسٹ گائیڈ لائنس ہم آڈٹ کریں جو کہ ہم رپورٹ سبمٹ کریں گے جس پہ فردر اس پہ ڈسکشن ہوگی. تو یہ فارماسسٹ کی رسپانسبلٹی کے اندر, یہ فارماسسٹ کے اسکوپ کے اندر سب کچھ آتا ہے. تیسرا ہے کہ انفیکشن ڈیزیز کلینکل راؤنڈس, بینگ این ID pharmacist, clinical pharmacist, we are actively involved. اور آپ जो भी जिस setting के अंदर, you should be actively involved in the clinical round with the physicians, because when you are part of the round, you will learn what actual isolation protocols are, how much compliance there is with those protocols, how we can modify things, how we can improve things. Only these things can only be learned when you are part of these things rather than theory. These things you learn through the rounds, practice and these things. Other thing is infection prevention auditor. As I mentioned, link liner के तौर पे आप infection control आप internal audits भी करते हैं और external audits भी करते हैं. Internal audits के अंदर आप अपनी pharmacy का audit करते हैं कि आपके जो pharmacist हैं क्या आपकी जो guidelines हैं, hand hygiene guidelines उनके साथ comply कर रहे हैं, क्या वो hand wash कर रहे हैं, क्या वो जो है पीपीज प्रॉपर पहन रहे हैं, क्या उनके नेल्स प्रॉपरली यानी कि ट्रिम्ड हैं, क्या उनमें नेल पॉलिश तो अप्लाई नहीं की हुई है, क्या उनके हेयर प्रॉपरली यानी कि जिस तरह ट्रिम्ड हैं, क्या जो आपकी फीमेल स्टाफ हैं जब एसेप्टिक एरिया में काम कर रही हैं तो उन्होंने हेयर को प्रॉपर कवर किया हुआ है. एनी सोर्स ऑफ कंटेमिनेशन आपने कंट्रोल करना है. ये सारे मेजर्स इसमें हम करते हैं. आप ऑडिट्स कर रहे होते हैं कि आपकी कंप्लायंस कितनी है, आप रिपोर्ट प्रेजेंट करते हैं और नेसेसरी मेजर्स जिसमें एजुकेशन हो जाती है, या अगर कोई स्टाफ ज़्यादा डेविएट करे तो उसके साथ इंडिविजुअली आप मीटिंग रख के उसको गाइड करते हैं सो दैट इंक्रीज कंप्लायंस. ये सारा ऑडिट इसमें आप इन्वॉल्व होते हैं. इसी तरह एक्सटर्नल और डिफरेंट, मैंने अब आईसीयू को ऑडिट करना है तो आई विल बी देयर इन द आईसीयू ऑब्जर्विंग कि जो भी नर्स हैं वो पेशेंट रूम इंटर हो रहे हैं, क्या वो हैंड रब या हैंड वॉश कर रहे हैं, नहीं कर रहे हैं, बाकी जितनी गाइडलाइंस क्या उनके साथ वो कंप्लाई कर रहे हैं, वो एक ऑडिट. तो ये सारे फार्मासिस्ट के स्कोप के अंदर फॉल करते हैं. टीम एंटीबायोटिक स्टूवर्डशिप, अगेन है कि फार्मासिस्ट अकेला नहीं है, फार्मासिस्ट ने एक टीम के साथ काम करना है. उस टीम के अंदर माइक्रोबायोलॉजिस्ट भी हैं. आपको एक अच्छा रिलेशन डेवलप करना होगा माइक्रोबायोलॉजिस्ट के साथ, सो दैट यू हैव चेक अपॉन एंटीबायोग्राम, आपके कल्चर ट्रेंड्स पे, आपकी डिफरेंट इस पे कि आपके पास बग्स कौन से ज्यादा आ रहे हैं, आपको उस पर अवेयरनेस होनी. आपको क्यों अवेयरनेस होगी तो आप फ्यूचर प्रोएक्टिव रोल प्ले कर सकोगे. जब तक आपके पास अवेयरनेस ही नहीं होगी इस चीज़ की कि आपके एंटीबायोग्राम क्या है, आपके कल्चर्स में ज़्यादा क्या आ रहे हैं, आप प्रोएक्टिव रोल बीइंग एन आईडी फार्मासिस्ट नहीं प्ले कर सकोगे. दूसरा इन्फेक्शन कंट्रोल नर्स, उनके साथ आपका लाइजन होता है कि आपके मेजर्स कैसे हैं. इसके अलावा जो इन्फेक्शन कंट्रोल कमेटी की मीटिंग होती है उसके अंदर आप उनसे लाइजन कर दे जब भी उसको अरेंज करना है, फर्दर उसके मिनट्स को नोट करना और जो प्रेजेंटेशन व्हाटएवर सिनेरियो. इसके अलावा उसके हैंड हाइजीन ऑडिट्स, इन्फेक्शन कंट्रोल और प्रेजेंटिंग आईडी इन्फेक्शन कंट्रोल नर्स के साथ आप कोऑर्डिनेट करते हैं. आईसीसी एंड पीएनटीसी, इसके अंदर वही होता है कि आप ओवरसीइंग एंटीबायोटिक स्टूवर्डशिप प्रोग्राम, आप एंटीबायोग्राम को रिव्यू कर रहे होते हैं और रिस्ट्रिक्टेड एंटीबायोटिक पॉलिसी या जो भी एंटीबायोटिक न्यू आपने फॉर्मुलेरी के अंदर इंटर करनी है वो पहले आईसीसी में डिस्कस करते हैं, फर्दर वो फिर पीएनटीसी के थ्रू उसको अप्रूव किया जाता है. आईडीटी में जिसमें मैंने बताया है केस में फर्दर कंसल्टेंट्स होते हैं, फेलो, रेजिडेंट्स और फार्मासिस्ट होते हैं जो कि राउंड्स के अंदर इन्वॉल्व होते हैं, जो डिफरेंट पॉलिसी फॉर्मुलेशंस के अंदर, डिफरेंट ऑडिट्स के अंदर वो कर रहे होते हैं. इसमें एक दूसरे को एजुकेट करना भी होता है और दूसरा ये होता है कि आप पॉलिसी इंश्योर करें थ्रू कॉमन इंटरेस्ट. और एट द एंड ऑफ द डे आपका गोल होता है कि पेशेंट बेनिफिट, हॉस्पिटल के अंदर इन्फेक्शन को कंट्रोल करना, ट्रीटमेंट को इम्प्रूव करना और इन्फेक्शन को कंट्रोल करना. Important part again, education. Pharmacist has been active part of education and training of healthcare professionals, जिसमें ASP हम नर्सिंग की ट्रेनिंग कर रहे हैं कि एंटीबायोटिक स्टूवर्डशिप प्रोग्राम के अंदर उनका क्या एक्टिव रोल हो सकता है. एडमिनिस्ट्रेशन टाइम पे क्या वो इंश्योर कर रहे हैं कि जो साइट है वो क्लीन है, क्या उसमें कोई ऐसा कंटेमिनेशन तो नहीं हो रही है, इन्फ्लेमेशन तो नहीं है, या इसके अलावा जो एडमिनिस्ट्रेशन टेक्निक्स हैं वो सारा नर्सिंग की एजुकेशन करना इस हमारा रोल होता है. इसी तरह फिजिशियंस की एजुकेशन करना, बाकी जो हेल्थ केयर स्टाफ है उनकी एजुकेशन और अपने फार्मासिस्ट जो कम्युनिटी है उनकी एजुकेशन. इंटरनल फार्मेसी ट्रेनिंग फॉर इन्फेक्शन कंट्रोल कंप्लायंस, जिस तरह मैंने यही कहा था कि पहले आप ऑडिट्स करते हैं जहाँ पे आपको लूप होल्स नजर आते हैं, वहाँ पे आप एजुकेशन सेशंस अरेंज करते हैं सो दैट टू एजुकेट योर स्टाफ टू इंक्रीज द कंप्लायंस. पेशेंट अटेंडेंस, आप जब भी राउंड के पार्ट होते हैं, आप जब भी ओपीडी के अंदर होते हैं, जब भी आप डिस्चार्ज डिस्पेंस कर रहे होते हैं तो उसके अंदर पेशेंट्स को भी और उनके अटेंडेंट्स को भी आप एजुकेट कर सकते हैं. ये वैसे कम्युनिटी के अंदर भी और ओपीडी फार्मासिस्ट पे या जब डिस्चार्ज पे डिस्पेंस कर रहे होते हैं उसमें काफ़ी इफेक्टिव इस पे हो सकता है क्योंकि आपने पेशेंट को एजुकेट करना है. मैं एक सिंपल एग्जांपल आगे जाकर भी चीज़ डिस्कस करूंगा कि आपने हैंड वॉश किस तरह करना है, हैंड हाइजीन किस तरह करनी है, सीरप्स यानी कि आपने हैंड वॉश करके अपनी टैबलेट को पिक करना है या सीरप को पिक करना है या किसी बच्चे को डोज एडमिनिस्टर करनी है, उससे पहले आपने गाइड करना है पेरेंट्स को या उनके अटेंडेंट्स को कि पेशेंट को एडमिनिस्टर करने से पहले आपने अपने हैंड वॉश करने हैं. ओनली आफ्टर दैट आपने फिर एडमिनिस्टर करनी है मेडिकेशन पेशेंट को. इस किस्म की जितनी भी एजुकेशन है आप इसमें एक एक्टिव पार्ट प्ले कर सकते हैं. Another important thing is surveillance and compliance. اس کے اندر اینٹی بایوگرام ریویو ہے، جس سے میں نے پہلے بتایا کہ آپ مائکرو بایولوجی کے ساتھ کوآرڈینیٹ کر کے آپ اپنے اینٹی بایوگرام پہ چیک رکھتے ہیں. اس اینٹی بایوگرام کے اندر آپ دو چیزیں دیکھ رہے ہوتے ہیں سب سے امپورٹنٹ. ایک چیز تو ہے کہ آپ کے جو بگز ہیں، جو بیکٹیریا ہیں، ان کی ریزسٹنس یا سینسٹیوٹی پیٹرنس کیسے ہیں، کیا وہ انکریز ہو رہی ہے، ریزسٹنس ڈیکریز ہو رہی ہے، کنٹرول میں ہے، کہاں پہ ہیں، یہ آپ اینٹی بایوگرام کے تھرو ریویو کرتے ہیں. دوسرا ہوتا ہے کیا ان کا نمبر تو انکریز نہیں ہو رہا، وہ بھی آپ اینٹی بایوگرام کے اندر فار ایگزامپل کوارٹرلی ہم کر رہے ہوتے ہیں یا منتھلی کر رہے ہوتے ہیں یا بائی اینولی اس میں آپ دیکھتے ہیں کہ کیا آپ کے بیکٹیریا کا نمبر انکریز تو نہیں ہوا. اس کو پھر آپ کرتے ہیں کمپیئر کرتے ہیں آپ کے ایڈمیٹڈ پیشنٹس کے ساتھ، تو اس میں ریشو میں آپ دیکھتے ہیں کہ کتنا نمبر انکریز ہوا، اس کا امپیکٹ کیا رہا ہے آپ کے. آپ ڈفرینٹ آڈٹس کر رہے ہیں. اس کے علاوہ آپ ڈیفائن ڈیلی ڈوز کے ٹرینڈس کو نوٹ کر رہے ہوتے ہیں. یہاں پہ آپ کو میں ایک چھوٹے سے گراف شیئر کر رہا ہوں. تو اس کے اندر آپ دیکھ سکتے ہیں سب سے پہلے ہم ڈیفائن ڈیلی ڈوز کے اندر وینکومائسن کی کنزمپشنز کو ریویو کر رہے تھے. تو کوارٹرلی کنزمپشن کے اندر ہم نے آبزرو کیا کہ وینکومائسن کی جو کنزمپشن تھی وہ انکریز ہو رہی تھی، پیکس آ رہی تھیں. ایون دو کہ ہم نے جو ڈی آر کیا اس کے اندر یوز ریشنل تھا. مرسا کو ہم نے دیکھا میتھیسن ریزسٹنٹ اسٹیفلوکوکس اس کا نمبر بھی بالکل ایسا انکریز نہیں ہو رہا تھا، کنٹرول میں تھا. باقی بھی جی پی سیز جو تھے وہ کنٹرول کے اندر تھے، کوئی ایسا ہمیں سورس نہیں مل رہا تھا. وہیں پہ جب ہم نے دوبارہ اینٹی بایوگرام کو فردر کریٹیکلی ریویو کیا تو اس کے اندر ہم نے دیکھا کہ جو اسٹیف ایپیڈرمائڈس ہے، جو کہ ایک کنٹامیننٹ ہے، جو کہ بریک ان ٹیکنیک وائل ٹیکنگ سیمپل وہاں پہ وہ کنٹامینیٹ کرتا ہے، کیونکہ اسٹیف ایپیڈرمائڈس آپ کی اسکن کا بگ ہے جو میری آپ سب کی اسکن پہ بلینز آف کوانٹٹی میں موجود ہے، اور اینی بریک ان سیمپل ٹیکنگ ٹیکنیک میں کنٹامینیٹ دا کلچر. تو اس میں ہم نے دیکھا کہ اسٹیف ایپی کا نمبر انکریز کر رہا تھا، اور وہیں پہ وینکومائسن کی کنزمپشن ٹرینڈ بھی انکریز ہو رہے تھے. ہم نے اس چیز کو آئی سی سی میں ڈسکس کیا، اپنی مائکروبیولوجی ٹیم کے ساتھ کوآرڈینیٹ کیا، اپنے آئی ڈی کنسلٹنٹس کے ساتھ ڈسکس کیا، میئرز لیے گئے. اور اس کے بعد کیا ہوا؟ جی
Sir, you have 5 minutes left.
اوکے اوکے میئرز لیے گئے. اس میں کیا ہوا کہ فردر جب اس میں ڈراپ ہوا نمبر تو اس کے ساتھ وینکومائسن کی کنزمپشن بھی ڈراپ ہوئی. تو یہ ایک آپ کے لیے ایگزامپل ہے کہ کس طرح ہم چیزوں کو کنٹرول کر سکتے ہیں. اس میں اگین اینٹی بایوگرام کوارٹرلی ریویو یا اینول ریویو آف اینٹی بایوٹک کنزمپشن ٹرینڈ، ڈی ڈی ٹیز، ڈیفائنڈ ڈیلی ڈوزز اور ڈیز آف تھراپی، جو بھی آپ اس میں میٹرک یوز کریں اس میٹرک کے تھرو آپ کنزمپشن ٹرینڈس کو نوٹ کر سکتے ہیں. ڈرگ یوٹیلائزیشن ریویوز ٹو ایویلویٹ کہ آپ کا یوز ریشنل ہے ارریشنل ہے، جب بھی آپ کو ضرورت ہو، یا اینولی ہم کر رہے ہوتے ہیں. ڈفرینٹ آڈٹس میں آلریڈی اس پہ کافی ایکسپلین کر چکا ہوں. فار ایگزامپل ہم آڈٹ کر رہے ہیں کہ پراپر یوز آف ڈی کولونائزرز، فار ایگزامپل کلور ہیکسیڈین باتھ یا جو اس میں میپائرسن کریم ہوتی ہے، کیا اس کا یوز پیشنٹس میں اپروپریٹ ہے. اس پہ ہم آڈٹ کر رہے ہیں، کیونکہ بعض اوقات پیشنٹس اپروپریٹ یوز نہیں کر رہے تو جب واپس آتے ہیں تو وہ کولونائزیشن اینڈ نہیں ہوتی. مرسا ڈی کولونائزیشن کے لیے ہم اس پروٹوکول کو یوز کرتے ہیں. رول آف کمیونٹی فارماسسٹ امپورٹنٹ. میں آخری اس پہ کہ کمیونٹی فارماسسٹ از آلسو اے کلینکل فارماسسٹ، اور اسپیشلی جو اس پینڈیمک کے اندر کمیونٹی فارماسسٹ کا ایکٹیو رول رہا ہے، اسپیشلی ٹو کنٹرول irrational use of different type of antibiotics، کیونکہ ایوری ون واز ہسلنگ فار ڈفرنٹ کائنڈ آف جو بھی دیکھیں سوشل میڈیا پہ ایون اس پہ جو ریومر آتی تھی، پیپل اسٹارٹیڈ ٹو ٹیک دوز میڈیکیشن. آئیورمیکٹن یوز ہونا شروع ہو گئی، ہائیڈروکسی کلوروکوئین ارریشنلی یوز ہوئی، ایزیتھرومائسن. اس میں ہم نے دیکھا کہ ایزیتھرومائسن اور ہائیڈروکسی کلوروکوئین کا انٹریکشن تھا، QT پرولونگیشن. اور بہت سے وہ پیشنٹس جو کارڈک ایشوز کے ساتھ تھے جن کو کووڈ نہیں تھا، they were without any symptoms but انہوں نے پروفلیکٹک لی اور ان کو کارڈک ڈرگ یعنی کہ کارڈک ایشوز کی وجہ سے ان کی ڈیتھس ہوئیں. تو یہ ساری چیزیں شو کرتی ہیں کہ کتنا امپورٹنٹ رول آف کمیونٹی فارماسسٹ ٹو کنٹرول دس irrational یوز. جیسے فار ایگزامپل ہمارے اس میں XDR ٹائیفائڈ ہے، ہمارے اسپیشلی جو پاکستان اور ایشین کنٹریز اسپیشلی ساؤتھ ایشینس کے اندر ہے، وہاں پہ ہمارے اس میں جو وائٹل ڈرگ ہے وہ ایزیتھرومائسن ہے، لیکن کووڈ کے اندر irrational یوز ہوا ہے اس کا. تو اس میں یہی ہے کہ اگر ہمارا کمیونٹی فارماسسٹ ایکٹیو رول پلے کرے اور پیشنٹ کو ایجوکیٹ کرے کہ آپ نے سمپل فلو یا ان چیزوں کے لیے آپ نے ایزیتھرومائسن نہیں لینی، کیونکہ اگر ایزیتھرومائسن پہ ریزسٹنس آ گئی تو پھر ہمارے پاس پیچھے اسکوپ بڑا کم رہ جانا ہے. ہمارے پاس صرف کارباپینمس کی آپشن رہ جاتی ہے ٹو ٹریٹ دا XDR ٹائیفائڈ. تو رسپانسبلٹیز آف کمیونٹی فارماسسٹ از دیئر ٹو مینیج ٹو ریشنلائز دا یوز آف ایزیتھرومائسن اینڈ سچ ڈرگز. اگین پیشنٹ کو ایجوکیٹ کرنا کہ ٹائیفائڈ کے اسپریڈ کو کس طرح کنٹرول کرنا ہے، واٹر کو بوائل کر کے یوز کرنا ہے، ہینڈ واش کرنا ہے، فوڈ انٹیک سے پہلے ہینڈ واش کرنا ہے. اس طرح بعد میں اپنے پیشنٹس کو فیملیز کو ایجوکیٹ کرنا. یہاں پہ میں نے ڈیٹا شیئر کیا ہے کہ ہمارے پاس XDR کس طرح انکریز ہو رہا ہے پاکستان کے اندر. یہ وہی ڈیٹس تھیں پیکس کی، یہ میں نے پچھلے سال کی تھی، اس سال کا ڈیٹا بھی اینڈ پہ شیئر ہوگا. تو میں نے اس میں تھا کہ جو پیکس تھیں وہی ٹائم تھا جس میں کووڈ تھا، تو اس میں ایزیتھرومائسن اور اس کا کافی اس پہ تھا. तो हमें make sure करना है कि इसका irrational use ना हो.
Sir?
Opportunities and take home message.
Yes,
Again, trust your abilities. Every pharmacist working, just let me complete. Trust your abilities. Every pharmacist working anywhere has a role of clinical pharmacist. Explore options for proactive role. As I said, proactive role, so that health system starts to depend upon you. Your knowledge is your strength. So always try to update your knowledge. अपने हमेशा डिफरेंट गाइडलाइन, जिस तरह पीछे रेफरेंस प्रोवाइड किए गए, आपने डिफरेंट आइडिया से गाइडलाइंस, वट एवर गाइडलाइंस, जो बुक्स इवन अब उसमें मौजूद है, आपने अपने नॉलेज को अपडेटेड रखना है. टू बी ए सक्सेसफुल आईडी फार्मासिस्ट, यू हैव ग्रिप ऑन 3 थिंग्स: फार्माकोलॉजी ऑफ एंटीबायोटिक्स, माइक्रोबायोलॉजी एंड थेराप्यूटिक्स. Your communication skills with the patient, healthcare professionals will play a decisive role in your success as an ID pharmacist. Role of pharmacist infection and prevention control demands leadership qualities along with practice and knowledge. आपके अंदर leadership होनी चाहिए so that आप leadership का role play करें, आप proactive role play करें infection control measures में, so that के health system के अंदर आपकी worth सामने आए और आप अपने इसमें effective role play कर सकें. Thank you very much. ये मेरा email ID है अगर किसी को कोई contact करना हो. Thank you very much.
Thank you so much, Dr. Rehan, for enlightening us on this topic, on the role of pharmacists in infection control, prevention of infections, different measures, and antibiotic stewardship program regulating the infection control guidelines. Thank you so much. Moving on to the session, I would like to introduce our speaker for this session. That is Dr. Saima Salim. If we switch to Dr. Saima Salim. Dr. Saima, are you here?
Hello.
Introducing you all to Dr. Saima Salim. She is currently working as an assistant professor in Department of Pharmacy Practice at Jinnah University for Women. She is doing her PhD from the same department, Department of Pharmacy Practice, Jinnah University for Women. Before that, she has worked as a healthcare pharmacist and also a regulatory pharmacist. And she has 23 publications in various peer-reviewed journals, and also spoke in 4 different sessions and workshops. The topic of her today's presentation is related to leadership. And the topic is that believe in yourself, your community needs you. Handing over to Dr. Saima. Dr. Saima, before you begin, I would like to request you that you speak in English because we are recording this session for the later use. So that would be very kind of you. Thank you.
Hello. Can everyone hear me? Hello.
Yes, you may begin, Doctor.
Hello. Are you
Hello?
able to hear me?
Yes, yes, you can.
Okay. Thank you, Aisha. Thank you for the introduction. Well, I'm Dr. Saima Salim from Jinnah University for Women. I'm here to talk to you over about unleashing creativity in my presentation today. The topic, no doubt, has great significance, and as you all would have realized, that it's a topic of escalating research for students and professionals of belonging to every walk of life. So, in today's presentation, I'll be just answering a few questions related to this that we have in our minds related to this topic. I'm having this, okay. Well, I do not have any disclosures to make in this presentation. So we will move further with the objectives. Well, while as we have acknowledged the power of creativity, and you all would have heard about people asking for creative ideas and generation of creative ideas and all those new innovations around you, we all have certain questions that pertain in our minds. So we will be looking at these questions in our presentation, beginning with a brief introduction and insight into the word creativity. What actually creativity is all about? Well, if you merely look at this word particularly, then you just, you look at the dictionary and you just have this word and you just get the meaning of, new ideas, or it all has to do something with the perceptions that you have, or any kind of vision, any kind of new vision that you have. So it's all about that. Different sociologists and motivationalists have given different definitions for us about creativity. But although we are looking at all these definitions, we still have to think that creativity itself has nothing to do with any activity in particular. We have to keep this in mind. There is no such activity, which you can call as creative or uncreative. There's nothing like that. Like, for example, like if somebody's studying arts and I say like arts is a creative subject, but pharmacy is not. So it's not like that. So creativity has nothing to do with any activity. It's your own perception. It's your own attitude and your own inner approach that would going to make it creative. But being, related to the field of science, we can just mold a definition a bit. Like if you're talking about scientific creativity, we can just say that it would be nice to say that it's coming up with new ideas. We do have to think of the new ideas, but we have to narrow down them. We have to narrow down them and then focus on one particular one which we need to elaborate. But overall, when we are talking about the statements said by all those sociologists and motivationalists, we do come to a central point that it is the central source of our lives. So, हम creativity के बारे में इतनी बात कर रहे हैं, where does it actually come from? So, is it our characteristics or anything which needs to be learned? Where does it come from? Well, no answer could be better given than from the Holy Quran. Allah subhanahu wa ta'ala in the Holy Quran, Surah Al-Isra, ayat number 70 says, and surely we have honored the children of Adam, and we carry them in the land and sea, and we have given them of the good things, and we have made them to excel by an appropriate excellence over most of those we have created. So it's clear from here that man is Allah's best of creation. So here we have its origin. Here we have its origin. We have it by birth. We have this quality by birth. Allah has bestowed us with great physical and mental abilities, and there lies our origin of creativity. So it's an innate characteristic which we are all born with. But we do observe that we do keep people asking, in every profession, people ask you for creative ideas, creative innovations. They ask you for that. But a few of us are there to present it, but most of us are unable to talk about it. Why? Why some people are not able to talk about it? It's just because, we do not have that belief in ourselves. We are unable to unleash that. We are not able to show ourselves that we are creative. And just also because a few of us might have, changed their motivation. They just think that their focus of intention is something else. They have become money, or they are money oriented or power oriented, or they're just moved a bit further from their focus. That's the reason. But when we are having these different kind of people and they are asking from us for creativity and innovation, they're talking about that, then what do you think there is the difference? We have a difference between creativity and innovation. There's a link between them. When you're talking about creativity, it's just about, generating of new ideas, imaginations, and possibilities. Whereas when you talk about innovation, it's something productive. You are giving it a shape. So creativity would ultimately going to lead you towards innovation. To bring an innovation, you need to be creative, but it's not necessary. Like if you're creative, you are having creativity or you are creative thinking, it's not always true that you are going to create, innovate something. It's not that. But in order to go for an innovation, you do need to be creative. Let us move further. If the characteristics is innate and some people are able to express itself and that's are not, then what do you think? How can you learn that characteristic, or you can unleash that? Then for that, you need to develop certain skills in yourselves. You need to focus on some points. And among those points, the most important that we have listed over here, make sure that you are open. You have to be open if you want to be creative. You have to encourage new ideas. You have to encourage approaches, new approaches, and you do not need to filter that. What do you mean by that? Like when you're talking about creative thinking, or you're talking about creative, or you are generating new ideas, remember that you don't need to be right. These are just ideas. They are not right or wrong. They are not good or bad. So first of all, you always have to think of ideas and you need to present them. You need to think over them. So do not try to filter your ideas. Have faith in yourself. Have a positive self-image. And do not think that you cannot do what you have been told, or whatever task you have, you cannot accomplish that. It's not that. You have to positively think over it. What will happen? Kya hoga? Zyada se zyada? Like if you are not able to change any situation, at least you would be able to, change your thinking over it. So think positively and present. Give your ideas, collect your ideas. आपको एक याद होगा, like the Archimedes principle that you all would have studied in the physical pharmacy subject, the law of buoyancy, which was given by Archimedes. What happened in that? कहाँ से आया था idea? He just encountered a problem and he was just thinking for a solution to that problem. Archimedes just was taking a bath at that time, and he just an idea just clicked to his mind, and he was able to find out the method for calculating the volume of any irregular shaped object. And it was simply an idea which he later worked on it, and he just put into a law, and it became one of the laws of physics. You have to be so open-minded. You do not have to doubt yourself. If you are curious, you are looking for an answer, you are embracing diversity, then you would definitely get what your goal is, and you would be able to solve the problems. You must listen actively, listen to all, and you have to love your profession. As we already said earlier, that it's not about the work you are doing, it's how you are doing, how you are interpreting it, and how you are analyzing it. So no need to criticize others. The idea might be wrong, it might come with nothing productive, but still, there's no need for that. Let us look further. You must believe that if you are going to think that you are uncreative, you would definitely become uncreative. So do not think that. Then, if you simply look, we have different steps which you can work upon to get, unleash your creativity. The idea basically begins with the idea generation, and that's your first stage, which we called as inception. During this period, like you just are getting your wild ideas that are wandering in your head, just collect them, let your bank, memory bank, just get all that knowledge that you have. Think of the past experiences that you have gone through, and then work for idea generation. Note down the idea from your past experiences, and that would be an original idea you would going to present. Then moving further, After thinking and after having that idea generation, you can you must take a little bit a step away from it. Why is that so? Because most of the scientists worldwide, even we have realized that while they are working, if you're working and you're just getting exhausted but thinking over our work again and again, you might get exhausted and you might not get the answer the way they are needed to be. So at a point in your work, you need to take a step away, let it incubate at the back of your mind, so that you can better get options for the better options and the answers for your questions. Then comes to the elimination phase. Eventually, when a little time would pass and you would just keep on thinking with that and that idea is incubating in your head, then automatically a spontaneous connection would occur between those ideas. The knowledge, you're going to link with that knowledge that you have and the past experiences, and you will strike with an answer to your question that you have in your mind. Then you can move further with the evaluation and verification of your idea to move towards the innovation that you wish to build. You can finalize your idea, check validity of that, and you can finalize your idea and then decide it, give it a shape, and move towards innovation. Talking about the profession of pharmacy. When we talk about the profession of pharmacy, like, do we really think we need the creativity in pharmacy profession? Well, we all know that pharmacy has an amusing history, and all that started just after the 18th century when the there was an industrial revolution and the rapid growth in the Western Europe and America. And after that, medicine emerged to be an important subject all around the world. This profession grew very fast. But in the modern era in which we are living, technology is moving at a very rapid speed, and we need to we need to stay side by side. We need to look at the changing trends. And in order to stay side by side with that, we need to develop skills. And these are the creativity skills that we require for our profession. We are encountering problems, and they do not just simply require a solution, they require creative solutions. We are going through an ultimate healthcare crisis, which we have seen all across, even in the developed countries as well. And the rapidly emerging technologies, everything has been moved to digital aspect. We have the M-health, the telemedicine, all that stuff. How we are going to answer those questions? We have these technologies around ourselves. So we need to do something, and we need to look at our profession again, but through a creative way. Even the way our courses are being managed, they are also being asked to be looked with creative thinking processes so that we can better achieve our professional goals. Now, if you talk about the creative corners, pharmacy is a very vast subject. There's no one subject that you can say that you are just looking for new drug development. It's not like that. You have a whole lot vast subject, and the pharmacy profession itself, we can say, that is a creative act. The biggest creative act in the field of science. You can look for new drugs development. You can go for the medical instruments. You can go for the policies and the drug control measures. You can practice models. No, you can practice new novel methods. You can bring in revolution in information and data management system, and you can offer unique positions for pharmacists. There's a whole lot ways that you can run. Because today, the person who is arriving at your pharmacy, whether it's community interest, it's your retail pharmacy, hospital pharmacy, or industrial pharmacy. Just be aspect mein aap dekhiye, people are continuously asking for innovations. And if you don't have that creative thinking in you, you cannot go for that innovations. We have some 21st century creative breakthroughs, and these are all not just about, drug development. Like we have some examples over here. We have the precision medicine. It's mostly about the targeted drug delivery, and with the help of the gene sequencing. And we have the revolutionizing the world, the health sensors, health technology, and which is effectively linking the clinical research. We have different gadgets here, and the researchers are ready to get data from the patients enrolled for the clinical research, and that has made the process much more easy. Then we are going towards open innovation. What's an open innovation towards? The major pharmaceutical breakthroughs the industries are working on, they are spending much more money on research and development. But still, the recent research says that much spending of amount on the research and development department in pharmacies is resulting in no new drug developments. The ratio has become very low over the past few years. And what's the reason behind that? They're spending extra money. They're spending extra money and they need to rethink over their processes. Like if they go for open innovation, they can better work on that. A common example that we have is about the anti-malarial drug that we have, artemisinin compound that we have. Where it was formed, it was worked at by Gates Foundation. They just financed the project, and then the product was licensed to Sanofi for delivery. But the basic research was carried out in a research institute, and there they were able to cut down their price into halves, and they were able to come up with open innovation. Prevention over treatment is better to be asked today, and we are working more on prevention as compared to the treatments. So in this way, you can look at different aspects and work on different aspects for pharmaceutical breakthroughs in today's pharmacy. So from where to start? All those professionals out there, all we need to do is we need to identify needs and then turn them into opportunities. We have to identify where does our clinic needs are at the time, whether it's community pharmacy, whether it's industrial or hospital site. Then you can identify the resources and make it happen. This is not an answer like we do not have the resources, we cannot do that. It cannot work like that. First of all, you have to bring up with ideas, you have to find opportunities, think over it, and then develop a platform, identify the resources, then make a plan and implement over it to move towards innovation. We are all here going through a pandemic of COVID-19, and most of us find it as an obstacle. But is it really an obstacle for creativity? Well, I do not think it's like that. COVID-19 has accelerated and it has unleashed new possibilities for healthcare professionals. Today's change which has taken place around the globe has been no other time in history. It's a fundamental change and it has revolutionized the world. So we have to work on it. We think of it as an opportunity. We have unlimited risks and opportunities to be addressed. And pharmacists can work in that. And pharmacists can work in that with creatively with multiple tasks. You can do multiple tasks at the moment. It's not simply that you can just work on simple drug development. You can work on the compliance issue. You can work on the clinical research analysis and medication therapy and management and drug information system, building up your drug information system. So summarizing up the whole process of creativity, you must look into the problem first, brainstorm your ideas, create rough drafts, and then you can move towards revision and revolution of your idea and then deliver the solution to your community. In the end, I would just like to say that you don't have any boundaries to embrace creativity. So be creative and light your community. Here are the references and the contact information. Thank you so much.
Thank you, Dr. Simons, for such a wonderful presentation. And moving on to our next session, the Pearl session, and it's a short presentation by our presenters. And on behalf of Giving Back to Pharmacy in Pakistan, I'm Mohammad Zishan Khan. Warmly welcome all the participants in the Pearl session in the first International Pharmacy Conference, and I hope you will get the maximum benefit from it. Our first speaker today is Dr. Khola Abid. She's a final year student, PharmD student at the University of Vet and Animal Sciences in Lahore. She worked as a science writer at Scientista UK, science communicator at Science Fuse UK, and science editor at Scientista Pakistan. And she's a professional reviewer at the National High School Journal of Science UK. In her institution, she founded UVAS Science Club, where she mentored youngsters about science communication, and currently heading a global training program created for science editors and writers and senior editors. Over to you, Dr. Khola. You can start your presentation. Thank you.
Assalamu alaikum everyone. This is Khola Abid here, Doctor of Pharmacy student from University of Veterinary and Animal Sciences. First of all, before moving further, I would like to express my gratitude to Sir Usman, to Mr. Siddiq, and to all other members for inviting me here and for giving me an opportunity where I can share my work with a much wider community. So I took many student engagement initiatives. I would like to share only a few of them here. To me, science is a thing that not only paves the way for advancements and technological revolutions, but it also equipped us that are needed to address the most prevalent problems of societies and nations. So having a background in health sciences and science communication, I took initiatives with particular emphasis on science education and health literacy. In Pakistan, we have only few science communicators who are really working hard towards developing an ecosystem of science in Pakistan. In spite of their all efforts, the culture of science in my homeland is not thriving as it is developing in certain other countries. What could be the reason behind it? Well, there are myriad reasons. 61% of students are enrolled in public sector school. And to our despair, there are no particular science rooms. Or if any lab is present, then those are with virtually no equipment or obsolete equipments. It's mean they are devoid of facilities that are needed for teaching science through activity work. By activity work, I mean experimentation. Experiment is the heart of science. I have an experience of communicating science with students of public sector. private sector, and I also communicated with the students of slums. But I observed in public sector, there is a lack of accessible equipments. Whereas in private sector, there is no access lack. Their labs are fully equipped and well furnished. The problem there is restricted access for both teachers and the students. Their administration is with certain fears of exhaustion of lab resources. And I guess this is because of the limited funding resources. So when I go to the students of slums, there are no particular classrooms, let alone the science labs. So the students of all sectors are equally unable to visualize the core concepts of their textbooks. And they all are compelled to rote memorization for sake of their grades. And this is what killing the true spirit of science and drastically suppressing the inquisitive nature of the kids with which they are born. So what if I present all these problems in front of you all? What could be the solution? Well, according to me, universities can play a pivotal role here. They can employ various pedagogical facilities to organize outreach programs focused on science and experimental learning. And this is what me and my team members did. With university granted funds, we launched many science projects. Various science outreach programs were conducted. In these programs, university students were mentored for communicating science with school-going students. Well, the main focus of these programs was to test the effectiveness of the model that we were thinking as the creative solution for the dearth of science labs for primary schools in Pakistan. And the other main focus was to renovate the research potential of sophomores. Really, our students think that science cannot be executed without sophisticated labs and costly experiments. Under this project, we mentored the students about designing cost-effective biological experiments with the help of raw material. And this was what created an atmosphere of creativity and innovation among the school kids. They started to thinking that if they want to visualize any concept, and the concept is well, they can design the models on their own. And this also cultivated the broader sense of contribution among the university students. Like they think if they want to pay back, then community pharmacy and hospital infrastructure is not the only thing. They can do that in a variety of different ways as well. This also cultivated inquiry-based learning and also created a sense of citizenship. Well, when I was conducting these all programs with help of some students, one of my classmates suggested to replicate this model for applied sciences. Here we were dealing with fundamental sciences like biology, physics, chemistry, and others. Health sciences is a domain of applied sciences. They suggested this because they were considering this can be the feasible and the most potential solution for increasing the health literacy in Pakistan. So we launched many campaigns. Our first campaign was about mental health awareness. We conducted 1 week-long activity, and these were the results that we obtained. Like the number of students who showed an interest increased amazingly over the number of the days. And this is what we got with our fundamental science modules as well. There, the number of students also increased over the number of the days. So in a nutshell, these results depict us that our activities really create and stimulate the interest of students towards science. This can be because our all experiments were cost effective. They were not in need of any dedicated lab. And all were safer to perform in regular classroom environment. and they were super easy to replicate in any other public school. So the things didn't stop here. Gradually, our communities keep on building. And we built it, the first and the foremost science club in US. So here we combined the different aspects of science with our outreach programs. Like art was inculcated. Science, yes, scholarly science was bridged and combined with digital designing. But there was two most prevalent problems. The first problem was this integrated network of science was only confined to US science. So we are launching our ambassadorship program. Via that program, students of different institutions would be able to combine us here, to join us here, and they will pass through training programs of each different wing. They would be able to model in their own institutions without. So there was another problem. Students of a literature wing, they were filling the lack of science journalism in Pakistan, particularly. Here, ancestors couldn't present any exemplary journal, an American Journal of National High School Journal of Science. Like these are the journals that were particularly curated. They are particularly catering the academic needs of their undergrad community. And they are really encouraging them to do more. And by publishing their contributions and their work, they are letting the world realize that this is what and this is how they are shaping their communities. So where are the voices of our undergrads? Why the research thing is still too abstract for us? The literature that is available in our journal is out of the scope of comprehensibility of an average undergrad. With the solution for it. But by situations, there was a time to address these things. So with the help of my team members, we launched the very first undergrad offsite journal. The most interesting fact about combining the two different narratives of science. One is the popular science, and popular science particularly deal with the general audience, and scholarly science deal with the scholarly community. But under the umbrella of this journal, needs of both subsets of a population. Different sections of our website can be visited. Evaluate these. So this is how this name is complementing the.
Dr.
Currently,
please summarize.
Okay, done. One youngsters training program. In this program, experienced editors are mentoring the students about ins and outs of scientific writing. In future, we are thinking of selecting certain candidates and to pass them through research training in clinical and healthcare sciences. And we are also thinking of launching a series of experiments and workshops while they aim healthcare scientists. The purpose of this would be to disseminate that physician is not the only godfather. The real brain power behind him is the healthcare scientist. And last but not least, we are also dedicated to create awareness of more career opportunities. For this also we will design these course modules. The main purpose of them would be to let the people know about the role of microbiologists, pharmacists, and nutritionists, etc. This is how when these college-going students will go for university programs, they would be able to make more conscious, successful, and directional choices. So can I share this was the work of me and my team members. Interested ones may join their hands. And this is a website of Popular Science Journal. So thank you everyone for listening to me. And this is my email. Interested ones may. Thanks a lot.
Thank you, Dr. Khola, for sharing your presentation and wonderful work you are doing for the uplifting of science. Our next speaker is Dr. Shoaib Shamas. He is a self-driven hospital pharmacist working as assistant manager in Shaukat Khanum Memorial Cancer Hospital. He has more than 8 years of experience and comprehensive achievements in leading the cross-functional team. He was a key member in getting SKM CHD JCI International Accreditation, and he has been awarded the Best Employee in 2013. And he is very keen and interested in the training and evaluation of the residency and internship program in Shaukat Khanum Cancer Hospital. Over to you, Dr. Shoaib.
Thank you, Zishan. The topic that was assigned to me is basically we did an innovative idea in the setting of hospital that is a virtual pharmacy internship program in COVID pandemic and in this area. And this is an innovative ideas. We have discussed in detail the process was going to conduct over the period of this whole pandemic situation. I have no financial relationship to disclose, and I have no discuss of off-level use of or investigational use of my presentation. The mission statement of hospital in which we are working here is to act as a model institute to alleviate the suffering of the cancer patient through application of modern method of curative and palliative therapy, irrespective of their ability to pay, and focus on education of healthcare professional and public and perform research into the cause and treatment of the cancer. So basically, on the base of this hospital mission statement that reflect the cause, we are working on education and training to healthcare professional and to provide best possible training and education during pandemic situation. And this is a challenge to initiate with a good idea that we need to continue this education and training to healthcare professional during this scenario. So based on that, we think as a team to create a new idea that we are going to launch a virtual pharmacy internship program in this region. And this is a one-time opportunity that we are going to initiate as multiple organizations are doing the education period. But this is an innovative idea to start a virtual pharmacy internship program. So based on that, we have multiple challenges, and same time we have other opportunities to initiate and to guide the community as well. And this is actually the give back to Pakistan. So during COVID pandemic, and we have multiple challenges. One of them is COVID-19, and with the help of that, we have a limited staff during that season and during that period. But with the help of other team members, as a pharmacist, we incorporated many multiple opportunities to guide and train along with the other training program we are going to conduct in this trust. So the other challenge we have to face, that is the availability of resources at the user end, that is the student, and the course material that are going to guide to the student, as well as what type of presentation we are going to give to the student which are virtually attending this virtual internship program. So based on that, we got multiple opportunities. We increase the capacity of the student. Basically, we have a limited resources that we are going to conduct less number of students from across the Pakistan. But due to this opportunity, we increase the number of students to guide and train and educate them in this region. And then the quality of education is based on, we initiate this training based on the experience of the presenters that we are going to present, or that have a good experience in communication and dealing with the day-to-day task activities. So we incorporated only the preceptors which are going to guide the student. These are based on ASHP preceptors, we have it. So the next thing we do, initially we design the whole plan, then we are going to launch this program to multiple platform, and then we use social media for this advertisement, and the advertisement is done only with the help of a two platform, and these are LinkedIn and Facebook. And expectations, we are that is unpredictable, that we do not know how much students are going to incorporate or how many students are going to take interest in this type of virtual internship activities. But the result which we received, that we reached to approximately, but more than that, 11.5K participants across the globe. And we received 200 application in just 120 minutes, because we have the limited resources. So we need to cut down that numbers, because we are not going to accept other application for that. But we have, if we got opportunity, that this is a high potential to get train more staff, more student, more professionals in that. Even one of the board certified pharmacists also apply in that course of internship program. So we design the multiple learning objective based on the leadership management is taught by the HODs and have experience of more than 15 years, like ambulatory care services, OPD services, with dispensing services provided by the trained pharmacist having the experience of more than 7 to 8 years. Aseptic services is broader in terms of inpatient and outpatient setting. We have a parenteral nutrition, and quality and patient safety is one of the primary key in hospital setting, as we are accredited by the JCI, and we are going to accredited by the other accreditation body. Like we have done oncology session and pediatric oncology, infectious diseases, inventory management, critical care, internal medicine, palliative care, and drug information services. As these are the key professionals that they are going to guide the students based on their pinpointed targeted course, and we have a defined course material for the student. And these are the established courses based on our previous experience with the ASHP, that we are accredited by the ASHP, and then we define our basic courses for the student are that going to taught in that period. The insight we receive from across the whole, from across the Pakistan, we have a 25 preceptors that that trained are going to student that train the student over the period of that's 1 month, and there are multiple of preceptors that are going taught the student, and we have 24 credit hours per course. And we deliver till date 85 lectures to the student, and we have the student across the Pakistan, including the Kashmir, and more than 7 students are recently trained on that. So this is the basically idea to initiate during that crisis situation, that we need to educate this community based on availability of the resources we have it. So that's the main point, that's the main idea behind that. And we have multiple other ideas that are initiated and they are in the process. This is one of the innovative ideas that we took part in that. And thanks to Give Back to Pakistan team who conduct this excellent opportunity for the community, professional pharmacist, and the student. So these are my contact details. Thank you.
Thank you, Dr. Shoaib, for such a wonderful presentation. Virtual training is the need of the hour in such unprecedented times. We should learn from your experience. So our next speaker is Dr. Anila Sharif. She is a doctor of pharmacy from Jinnah University for Women. And during her studies, she was actively involved in the research activities and also participated in many volunteer in different organizations. And she is currently working as a quality assurance officer at a pharmaceutical company in Pakistan. Over to you, Dr. Anila.
Hello everyone, I hope you are all doing well. And it is a pleasure to be as a presenter here, and my topic of presentation is volunteerism, a pharmaceutical story. Basically, it's my story of volunteering in a thalassemia care center.
Dr. Anila, can you share your screen, please?
Okay. I think I can share it. Is this visible to you all?
Yes, go ahead, please.
My topic of presentation is volunteerism and pharmacist story of volunteering. Basically, it is my story of volunteering in a thalassemia care center, and I have no conflict of interest to declare here. So basically, thalassemia is a genetic disorder in which body doesn't have enough hemoglobin, and the lack of this protein leads to oxygen deficiency in tissues and cells, and which eventually cause shortness of breath and tiredness. This condition is called anemia. And when we talk about the types of thalassemia, we have two major things, that is the severity of thalassemia and the parts of hemoglobin, that is alpha and beta. And alpha thalassemia protein is missing with all thalassemia minor, and the beta protein is infunctional or malfunctioning, that is thalassemia major. People with severe or major thalassemia usually found out about their condition in childhood, usually before their second birthday. Since the symptoms are very severe anemia in early age, one way to treat anemia is to provide the body enough healthy RBCs to carry the oxygen. This only can be done by blood transfusion. And the permanent solution for the thalassemia is bone marrow or stem cell transplant. Sometimes we give medications or vitamin supplements to the thalassemia patient to help them about their physical conditions or their symptomatic care treatment. Talking about the statistic in Pakistan is that, considering the harsh reality of Pakistan, where 5 out of every 100 people are affected by thalassemia, with approximately 9 million people carrying thalassemia minor and about 90,000 to 1 lakh people are carrying thalassemia major. And the death rate, life expectancy of thalassemia kids are not enough. That is below the global average, which is 10 years in Pakistan, which is very low. That means the thalassemia patient not live more than 10 or 12 years of life. The organization which I have been working with is Health International Welfare Trust. They have different domains of working. They have thalassemia care center, they have educational program, they have water purification programs, and they have the specific initiation of health volunteering program, which was inaugurated in 2013. They provide all the expenses of thalassemia care to less privileged families, from giving them blood transfusion to lab test and their OPD and their iron chelation and their desferal therapy, etc. They also provide quality education to the thalassemia kids. There are more than 240 children registered in this organization, and there are more than 1,000 volunteers working in Pakistan in different domains of the organization.
Dr. Nina, a bit louder, please, or take the mouthpiece near to the.
As a volunteer, our best role is to make the thalassemia kids happy and full of life. We arrange different activities with them. We play games, we play Ludo, play carom, and we play painting and different activities during their blood transfusion, so that they don't feel down and dizzy. Sometimes we watch movies and cartoons, and we also arrange some educational activities with them. Volunteers with all with they all provide the items of the activity and we also celebrate their birthdays after 2 to 3 months, and we also provide gifts and different things that were need to the thalassemia patient. And the organization also celebrates the national days, and we all have tried to give our best to make their life more happy and enjoyable, so that they can enjoy more and think less about their miserable health. As same as we play our part to counseling the parents towards the health of the patient, and we give them hope and our empathy that we are all together in this condition as a family and as friends. By giving them hope and our empathy, I think it is really necessary for us to be more empathetic toward humanity, which makes our life more meaningful. And there's a saying that say volunteers don't get paid not because they are worthless, but because they are priceless. And I have a message that life is worth living if you are living for others, and hope is the greatest gift that you can give to someone. It make their life more bearable. Join hands to make the Pakistan a better place to live in, and as soon as possible we can eradicate the thalassemia major from Pakistan. Thank you so much, Giving Back to Pharmacy, for giving me opportunity to share my experience here. And there is the details of my account if you want to contact for any details about the thalassemia test. Thank you so much.
Thank you, Dr. Anila, for such a wonderful presentation and sharing your experience as a volunteer in Welfare Trust, which definitely helps us reach larger community and people will learn from your experience. Our next speaker is Dr. Waqas Miraj. He is a final professional PharmD student at University of Jamshoro, and he has done internships in different community pharmacies, including Diwago and Civil Hospital, Hyderabad. And he is an active member of Pakistan Pharmaceutical Student Federation, and he has been a contact person for the International Pharmaceutical Student Federation Asia Pacific Regional Office, and he has represented in various research projects, including the antimicrobial resistance and pharmacists' role in universal health coverage in rural areas. Over to you, Dr. Waqas.
Thank you, sir. Am I audible to you?
Yes, Waqas, go ahead, please.
All right. Assalamu alaikum and good morning to everyone. I am Muhammad Waqas Miraj, student of final year pharmacy from University of Sindh, Jamshoro. I'm thankful of giving back to pharmacy in Pakistan and Sir Siddiq and for inviting me in this beautiful and futuristic event that is surely going to be a success. So these are some points that I want to put forward before my presentation. I have no financial relationship to disclose. I will not mention any person directly or indirectly, with an exception. Everything that I will discuss is based on my personal experiences, and you are not bound to agree with all of that. So first of all, why do we choose a profession? Why do we choose pharmacy? What are our motivations behind our decision about our career? So let me tell you some motivational factors that I think play a major role before we choose our profession. Number one, how much can we earn? So according to US News and World 2020, pharmacist is the fourth most earning profession in the world, even more than the physicians and nurses. What is the scope? Where are our services required? Number one, antimicrobial resistance, which is quickly becoming a global threat because of the irrational and careless use of antimicrobial agents. And a pharmacist can prevent this disaster by his or her rational prescribing skills. Number two, medication errors. These errors may arise due to the human errors, and these can be prevented by a pharmacist through his prescription handling skills. Also, as you people might not know about this, every year almost 400,000 to 500,000 people in Pakistan die because of these medication errors every year. Now you see, this is quite a huge number that can be prevented by adequate incorporation of pharmacists in the clinical setups. A pharmacist with a good management skills is more worthy than a person with only expertise in the management. Interpersonal collaboration. A pharmacist, being a counselor, has more good interpersonal communication skills, and he can promote such interprofessional collaboration. between physicians, nurses, etc. A physician always looks for a pharmacist for adjustment of dose because the difference between a drug and poison is only of the dose. A nurse always look up for a pharmacist to direct the dose that has to be administered. Number three, how will it impact our approach? How pharmacy will impact our approach, our thinking? So pharmacy widens up the perspective of your approach and enables you with comparative and critical thinking skills that no other profession offers. Moving on. So what it takes to be in spotlight. As you see this quotation, you don't have to say everything to be a light. Sometimes a fire on a hill will bring interested people to your campfire. Let me give you an example. Consider yourself in a vast desert with no one around you. You lit up a fire to attract other travelers. You see a caravan coming towards you. You need help, so you get along with them. That caravan takes you to other people. You share insights with them, you share your experiences, and here your journey starts. So metaphorically, this fire are your skills, your abilities, your expertise that you promote, that you showcase to the world. And when the opportunities see the potential inside you, they will come towards you. And as a platform, they will offer you to other organizations. So make yourself as much capable, skillful, professional, and groomed that your reputation brings the opportunities towards you. So let me tell you some steps to be successful. Find a platform. Find start from a little platform. You don't have to score big. Just start from somewhere. Acquire new skills. Don't get settled on few skills. Identify weaknesses to work on, because remember, the moment you get satisfied with your development, your progress will be stopped. There is always a room for improvement. Work on self-development. Respect your teachers, seniors, and mentors, because these people are the backbone of your success. What I have achieved till now is the ultimate efforts of my teachers, on whom I can take pride. And if you follow such steps, the opportunities will become available to you. So let me tell you guys about myself and my journey. I started my journey in Pakistan Pharmaceutical Students Federation as an ordinary member. After working on different designations, excelling, and acquiring skills from this association, I took part in different team-based competitions of IPSF. And I made a team with Ms. Nirmal Khan. She is also a student from LUMS Jamshoro, final year. We participated in APRO events like Asia Pacific Regional Office events like patient counseling event, clinical skills event, Beyond Health Hackathon, industrial skills event, and many others. So these are some glimpses for our achievements. We took second position in the clinical skills event 2020 from April. This event was based on different aspects of clinical pharmacy, including the toxicology, microbiology, immunology, cardiac diseases, neurological diseases, the drugs used in them, etc. More than 10 plus teams competed against each other in this competition, and we came out on second position. And we were the top scorers in the semi-final. We were also the semi-finalists of Patient Counseling Event 2020 from APRO, in which you can see two other members. And see, that's how you promote yourself. You take chances. So what message I want you guys to take home with you before I conclude my presentation? Number one, you have to step forward for your own success. Because remember, no one is going to do hard thing for you. You have to cover extra mile all on yourself. You have to prepare yourselves for each and every situation. Because as Darwin said about the survival of the fittest species, only those people can be successful who stood up and struggled for themselves. You just have to believe on yourself, because without believing on yourself, you cannot proceed in your career, in your profession, in your education, etc. And remember, don't be shy to make mistakes, because what you learn from these mistakes will be much better than not trying at all. Every successful person was once an ordinary, unknown individual who got renowned because he or she stood up for themselves. And in last, I want to thank you all for listening me, and that's all from my side. And I hope that you will make our country proud with your talent, your ambition, your dedication for this profession. Thank you so much.
Thank you so much, Dr. Wakas, for your wonderful presentation, and thank you for enlightening us. Our next speaker is Dr. Zahid Saeed. He's a patient care-oriented young pharmacist having a diversified experience of working in Surveyed Pharma, one of the biggest chain of pharmacy in Pakistan, and he's a former trainer and ambulatory care pharmacist in the Aga Khan University Hospital, Karachi. And currently he's serving as in the public sector hospital. There is the THU hospital in Safdarabad. Over to you, Dr. Zahid.
Assalamu alaikum, everybody. Can you hear me?
Wa alaikum assalam, Zahid. Yes, we can. Please go ahead and share your screen.
So, this is Zahid Saeed, a hospital pharmacist from a public sector hospital from Punjab, Pakistan. And as you have given my introduction already, so I'll waste time in disclosing that. I have no disclosure. And to start with, these are all the steps which I took from just Googling. If you Google on giving this command, that how to solve a problem. So the main agenda for doing this was to create some change in the public sector, because that is the most deserving area in health sector in Pakistan, because all that fund which comes to the government comes from the average taxpayer. So they're the most deserving people to be served. And then when I was recruited to be a public sector pharmacist, what were the motivations for me to be in the system? They they didn't ask me for the money, neither any reference was taken. So these were the motivating factors for me. Like if they are not asking for anything except the merit, then I should be giving back to these people. And then I came up with the idea for solving the problem which I've already learned with my experience. So these were the things. If you like Google it, it says define your problem, clarify the problem, define the goals, identify the root causes, develop an action plan, execute the action plan, evaluate your results, and continuously improve. So when I came into this public sector hospital, by that rational approach, I figured out these are the problems which are present in my healthcare system. The staff was untrained. There were understaffing, like no just division of labor. The staff which was already working there was of a rigid mindset. They don't want to improve, they don't want change, they're suffice in that, and they don't have any vision. All they're doing is to come to the job at 8 a.m., go back at 2 p.m. They're happy with that. They don't want to excel in the field because they haven't been trained and they haven't been instilled with this thought that you can do more and bring change in the society. And being in the public sector, I saw there was much of conflict of interest. Like every other person was, sorry to say, a quack who just have some dispensing experience, is a doctor in his peripheral area, and he is taking drugs from the hospital and dispensing and even administering drugs to the patient and being um, a quack over there. With that, there was obviously a poor management. That's the dilemma of our country. Like the clerical staff is taking over and they're managing things according to their limited knowledge and experience. And they had obviously we know that how much of the health budget we have in our country, so we had limited resources. and and one of the most vulnerable problem was the pilferage of the drugs. Sorry, drugs were being stolen from the pharmacies, from the drugstores, and we couldn't help it out because they were new to the system. So, in order to cater all these problems, we did some things, we took some steps to figure out these problems. We did the internal audit of our indoor and operation theater and emergency areas. We did inspection of the drug storage areas. Obviously, they were not placed in, in those controlled environment. There were poor administration techniques used by the dispensing and administrating staff, and all of these problems were taken by observing and during the rounds and by questioning the staff. How do you do it? Who told you? Where have you been getting this kind of training, and where is the reference for that? So whenever we would ask them any question, they would think, yes, there must be some reference, some solid proof for what we are doing. Most of the time they would say that हमने तो ऐसे ही सीखा है, we have been trained like this, we have been doing this for many years, nobody ever questioned or told us, and nobody owns the public sector hospital setting basically. So I guess my presentation is stuck. I start moving on. Can you hear me? Hello? My presentation is stuck, I'm sorry. Dear moderator, could you please solve this problem?
Dr. Zahid, we can hear you. You can try to open your presentation, please. It's fine.
I have already shared my presentation. Yes, it has started working. Apologies for that. So
Please
moving on to the next slide. All of the hospitals have their built-in goal setting or mission statement, which was already there. Like they have already written, we are committed to provide healthcare of best quality to the patient, irrespective of the caste, creed, and socioeconomic status. But that was not being taken place. They were all into their those old rituals and old custom practices which were being followed from ages, and there was no recognition of a pharmacist and no need according to them, because for them the physician, the doctor, and the nurse were the engine for the healthcare system, and even without the presence of a pharmacist, the system was already working. Like when we joined the public sector, there was no pharmacist for like more than 1.5 years, and then thanks to the public sector and government, which recruited more than 400 plus pharmacists to the Public Service Commission and appointed in all over the Punjab. And 5 of us came to this sector with a vision to make the pharmacists recognized in the healthcare setting in government sector. And we have taken such steps for that, which will be shown later, inshallah. So in order to get all these problems, we developed an action plan and we did talk to our administration. Then these are the flaws we have taken, and this is how we are getting into loss. The public resources are being wasted because of these practices and these careless behaviors. So we listed all the problems, we compared the pros and cons, like if we change the things, these are the benefits, these are the do's and don'ts. And we then divided the goal with the chunks, like we were 5 in number, we divided the tasks to be performed in the morning, evening, and night shifts. And then we made the roster accordingly. We took the responsibility of different areas which were already there, like the uh, so main store, which is the warehouse of the pharmacy, the dispensary, which is the outpatient pharmacy. And then these were the things which were already there. We found that there's some gap for the proper management of the indoor patients, the emergency labor room patients. So we came up with an idea to make a centralized or indoor pharmacy where we would govern the medication throughout the hospital, and there will be a second check before the administration of the drug to the patient. Like before the system, uh, the doctor would write a prescription and the patient would go to the dispenser or a nurse, and she would directly inject or administer the drug to the patient without a second check. And that second check was missing. So government recruited us, appointed us, and asked us to be the second check to prevent the errors for administration, for reviewing the prescription, for maintaining the hospital inventory, for managing the expiries and anything else. So we then executed the plan. If you look at the left side of the picture, like this is a mini emergency area where the patients were being treated. If you see at the cabinets, the drugs were already there. The patient would come up with a prescription and the dispenser would pick the drug from the cabinet and will administer. Like there was no office, no second check for the pharmacist.
Please summarize.
Yes, I'm smarting up. So there was some underutilized area right next to the emergency department, which we, alhamdulillah, turned into a central pharmacy. We brought the racks and the furniture, installed the air conditioner for the proper placement of the drugs. We made the roster for the nurses for helping us out in dispensing the drugs. And then we made a roster in morning, and evening, and night shifts for the proper supervision of the staff and the medication and stopping the errors in short. And then we did some customized uh, things for the patient facilitation, making a window and then placing the drugs and labeling them accordingly. And then we got a phone line for responding to any toxicological query or any ambiguity and responding to some error in prescription to the doctor. And then we came up with some protocols, like you must have seen some pre-open post-op protocols, like patient doesn't have to come for every single thing. He or she would come by prescription having a protocol named over it, and we would give all the pack to the patient instantly without wasting his or her time. And then we recently introduced this drug information system for answering to the queries of the doctors for proper prescribing things, and telling the junior staff, the nursing staff for the proper administration techniques. And all of these things are in loop because I believe there is brightness at the end of the tunnel. We are still working on it and improving on things. And to sum up, this is my contact information, and this is what we have been doing in public sector hospital so far. Thank you.
Thank you, Dr. Zahid, for a wonderful presentation. Our next speaker is Dr. Bisma. Sorry for keep you waiting for a long time. Dr. Bisma is a PharmD and has more than 5 years of experience in as working in private and public healthcare sector in Pakistan. Currently, she is managing the breast cancer initiative of the Ministry of National Health Services Regulation and Coordination, Pakistan, and she has been a support in COVID-19 response group. She is also leading the technical and pharmacy wing of the Pakistani diaspora health initiative called Yarane Watan, reaching out to the larger community through this initiative. And she is currently pursuing her Master in Public Health from King's College London, and also a member of National Alliance for Women in Pharmacy in Pakistan. Over to you, Dr. Bisma.
Thank you so much. Can you guys hear me?
Yes, Dr. Bisma, please go ahead and share your screen.
Okay, great. First of all, thank you so much for inviting me and giving a chance to share my experiences. Just let me share my screen. Can you all see my screen?
Yes, Dr. Visma, we can.
Okay, great. So basically, the things I want to share through in this conference was the expansion of pharmacist role in COVID-19 and beyond. It's 6 months since we have first case emergence of COVID-19 in Pakistan, and as you can see, the stats are getting better day by day. But the most astonishing thing about this COVID-19 in Pakistan and overall is this how remarkably the pharmacy profession prove itself to be diversified and innovative and expensive in terms of the pharmacist can play in their role in like every field, and they prove themselves to be like this. So starting from the Vyarane Vat initiative, we were about to launch it as a clinical missions, but then for COVID-19, we decided that we would want to do it in a digital way to suit the COVID-19 situations because of the border closures and the hospital closures and all these things. So it was launched on April 26th by PM Saab, Dr. Zafar Mirza, the then Health Minister, and Zulfi Bukhari. So this is the initiative of Ministry of Health and Ministry of Overseas, and what we aim to do by this initiative is connecting the two ends of the experts, the local institutes in Pakistan and the brain in overseas, our overseas Pakistanis which live there. So while serving their jobs, they can contribute to experts in experts fields in Pakistan as well. And if you can see the major, we have so many objectives lined up, but the main objective which I focused during COVID-19 was the strengthening pharmacy reforms in Pakistan and how we could gauge the potential of our pharmacists, diaspora pharmacists especially, to gauge the activities in COVID-19 and to be useful. So by doing that, we started by outreaching Pakistani pharmacy diaspora in UK, USA, UAE, and we are in talks with them that how can we harness the power of pharmacists and their expertise, their visions, their experiences from all over the world to give back to pharmacy profession, and that's how I came to in conversation with GBTT as well, that how we can do this. So we are in conversation with a lot of pharmacy diaspora groups. And in COVID-19, in March and April, this has leads to like many initiatives. Which two I would like to mention it here, which I am very proud to be a part of. One is that with the UK pharmacist, what we managed to do, we managed to compile 10-step protection guidelines for pharmacy teams in Pakistan, not just for pharmacists, but pharmacy teams in Pakistan. What we knew we were lacking the guidelines for pharmacy teams because everyone was thinking about the protection of nurses, the doctors, and the staff in the hospital, that you have to provide them PPEs and protective gear, but no one was thinking about the pharmacist and pharmacy teams, which are actually more closer to the COVID-19 infections, because the OPDs were closed, hospitals were closed, they were not catering chronic patients. So the patients, obviously they tend to go to their pharmacies, nearby pharmacies, as they were among those entities which were allowed to operate 24/7 during lockdown. So what me and my UK counterparts did, we managed to get those 10-step guidelines for pharmacy teams. We get them endorsed from International Federation of Pharmacy, Commonwealth Pharmaceutical Association, then there's a doctors, our regulation authorities, DRAP and Pharmacy Council, and then Ministry of Health. We managed to write an editorial about this, which got published in Journal of Pharmaceutical Policy and Practices, and this single article has reached 29,000 publications, accesses, and it was cited by more than 20 in case studies, and set as an example that how pharmacists in Pakistan came together with all over their diaspora counterparts to give that guidelines. And actually these guidelines were proved to be an example for the other countries to follow guidelines like these. And because of this, we would feature in the International Federation Pharmaceutical. They did a webinar on this, that the pharmacists, what are they doing at the front line. There were pharmacists from hospitals background and community pharmacy and academia, and all that sort of for different experiences they came together to share their experience with how they are doing in COVID-19. And because of this, we were appreciated by then Minister of Health, Dr. Zafar Mirza, that these are also our frontline heroes, which needs to be acknowledged of their services. Then the other parts which COVID-19 highlighted was the gender equity part and the pharmacy workforce related issues. When we talk about gender equity, we know that the women, they make 70% of the workforce, but they are never acknowledged or even discussed with that how much difficulties they are having in their professional and their personal life. So we did an article, we wrote an article again with our diaspora counterparts, that how they are seeing, they're facing the gender equity thing, or their work from home, and their work life, how it has been blurred by COVID and highlighted. And then we get all our experiences, and we managed to write that article as well. So it's very cognizant. We should be very cognizant of fact, and for our male counterparts, it's very important to always support your female colleagues in whatever capacity you can. Then again, through Yarane Watan, I would have been made a part of NAWP, which is National Alliance for Women in Pharmacy. It is formed by Pakistan Pharmaceutical Association Pakistan, which is a regulatory body, and this is a specific body for women in pharmacy to highlight their role, to facilitate them, to showcase their strengths, their stories, and how they are making the pharmacy profession better. For this, we launched 2 campaigns, which will be reported in the International Pharmaceutical Federation report and the case study. We invited, one campaign was for the photo stories from the front line, whenever they are working in the pharmacy or hospital or academia, wherever they are, or in the ICUs and emergencies, they just needed to click their pictures and send their names. And the second campaign we launched was about their stories, that the same thing, how they are coping, how it's been difficult for them and their families to be at the front line and go to home as well, keeping the things in mind that they don't infect their families. So we worked on those campaigns, and they are underway for the Pharmaceutical International Federation report. So that's what I just all wanted to share, and we are open for ideas from Yarane Watan platform. If you wanted to know more about the initiative and the work I am involved, I am doing, and if any got ideas for teaming up, that how we can make this pharmacy profession better in Pakistan, so just reach out to me, email me, or you can LinkedIn. So thank you so much for listening to me.
Thank you very much, Dr. Bisma, for your presentation. And with this, we conclude our first half of the day one of our Innovation and Pharmacy Conference in Pakistan, a virtual conference. And thank you all the moderators, all the speakers, and all the viewers who bear with us for 3 hours. And we'll have a lunch break and prayer break now. And at 3 p.m. Pakistan Standard Time, we will have our keynote presentation by Dr. Lee Shan, and I would like to invite everyone to attend that. It will be on live on YouTube channel, and after that, we have 3 more presentations for second half of our day to wrap up day one of our presentation. So see you guys at 3 p.m. on our YouTube live channel for the keynote speaker. Thank you very much.
Thank you.